ம், ம். பார்த்தேன்.
ஆனா அவங்க இங்க இருந்து எடுத்துட்டு அங்க வந்து பண்ணணும் அப்படின்னாங்க.
ஆ
அதுக்கு நான் பண்ணலங்க.
ரூம் வந்தேன். இப்பதான் ரூம் வந்தேன். கீழே போயிடல. ஆமா. அதான் இருக்கேன். எப்படி இருக்கேன்? பரவாயில்லையா?
ஒரு காக்கா போனா அமெரிக்கா
ம். துணி மனுஷன்.
ஆ
துணி மனுஷன்.
ஆட்பாலுக்கு 13 அடிக்கணும். எல்லாரும் இருக்கா
Sir, Balaman, sir. Hello.
Sir, Balamuram sir, good evening, sir. Good evening, sir. Dr. Siddhil, sir. Sir, you can just unmute, sir. Yes.
So, good morning to you all. Good afternoon. Good afternoon, Sendal.
Yes, sir. Good evening, sir. So we'll start in just another 5 minutes, sir.
Sure. We are ready. So, slide மட்டும் நீங்க ஏதாச்சும் ஸ்லைட் வச்சிருக்கீங்களா? நான் ஸ்லைட் ஷேர்
Sir, you can share, sir. You can share, sir. That will be easy. Screen sharing option will be
வாய்
used.
தராங்கம்மா நாக்க நீட்டுங்க நாக்க மேல தூக்குங்க செந்தில்
சொக்கலிங்கம்
good evening, செந்தில்.
சொக்கலிங்கம்
Yes, sir.
Yes, sir.
Good evening, sir.
Good evening, sir. பாலாபுரன் சார்.
Sir, good evening.
Yes, sir. செந்தில் பழனியப்பன் சார் வந்து பழனிசாமி சார் வந்து ஸ்டார்ட் பண்ணிடலாமா எப்படி?
And I'm just calling him, sir. Otherwise, we will start, sir. அவர் இடையில கூட வந்துக்கிறேன், sir. Yes, sir. I just call once, sir.
சார் ஸ்லைட் ஷேர் இருக்கா சார்?
வந்துருக்கு சார்.
வந்திருக்கு சார்.
ஃபெலோஷிப் சர்டிஃபிகேட் கோர்ஸ் வந்துருச்சு சார்.
நாக்க மேல சரி.
ஆனந்த் எல்லாரும் நாக்கு நீட்ட போறாங்க.
தேட்டர்ல இருந்தாரே அவ்வளவுதான் முடிஞ்சு.
டான்ஸ்டெக்டமி பண்ண பிறகு நாக்கு நீட்டினா நான் பேஷண்ட் நல்லா இருக்காங்கன்னு அர்த்தமா சார்? ரொம்ப நாள் ஆச்சு இந்த கேஸ்லாம் பார்த்து.
சார் ஸ்லைட்ஸ் தெரியுது சார்.
ஓகே சார்.
சரி, ஸ்டார்ட் பண்ணி.
இன்ட்ரடியூஸ் பண்ணும்போது இந்த திஸ் டீம் இஸ்னு சொல்லிடுங்க சார். நான் அப்படியே ஃபாலோ பண்ணுங்க சார். ஷூர்.
ஓகே.
டூயிங் இட். ஏற்கனவே எப்படி சார் சொல்ல போறீங்க? ஏற்கனவே 48 பேர் சேர்ந்துட்டா இன்னும் 2 சீட்டு தான் இருக்குது அப்படின்னு சொல்ல போறீங்களா சார்? இல்ல வந்து
அப்படிலாம் சொல்லல.
இல்ல சொல்ல புக் விற்கிறதுக்கு லாஸ்ட் 2 காப்பீஸ் அவைலபிள் வரல. அந்த மாதிரி only 2 copies are available. Only 2 flight tickets are available ங்கிற மாதிரி தான் அது.
அப்படிலாம் சொல்ல வேண்டாம் சார் நம்ம.
Sir, Anand sir, we'll start, sir.
We'll start.
Yeah, Palisam sir might join in between. We'll try to accommodate.
Okay, sir.
Yes, sir.
Okay, sir. At the outset, I would like to welcome all the members for today's webinar. Today being the 4th day of the TNCGP IMA State Con. Today's topic is based on neurology. Like all cases are clinical scenarios, and one topic is from radiologist, and he will be taking when to take what imaging for a headache. So with this, I request our chairman of studies, Dr. Sendil, to give the IMA prayer and physician. Sendil, நீங்களே சொல்லிடுறீங்களா இல்ல திரும்ப?
Yes, sir. I will tell, sir. It's ready, sir. I will tell, sir. Yes.
Yes, sir. Yes, sir.
Yes. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. இந்திய மருத்துவ சங்கம் வேண்டுதல். எஸ் சார். எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி, அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி, பிணி போக்கும் பெரும்பணி ஆற்றுவோம். தேங்க்யூ சார்.
physician பேர் சொல்லிடுறீங்களா செந்தில்?
எஸ், ஐ ஃபினிஷ் சார்.
Yes, Senthil.
Dear Lord, yes, sir. Physician prayer. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee, I pray. Give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart our guilt and worldliness, that with the simple faith of a child I rely on thee. Thank you, sir.
Request.
Sir, it's not audible.
Now I request our Director of Studies, Dr. Senthil, to give the presidential address for today's meeting. Welcome address and presidential address with Senthil.
Yes.
Senthil?
Yes, sir.
Senthil,
Yes, sir. Yeah, just a minute. Yes, sir. At the outset, I welcome all our delegates who are registered in large numbers, and moderator Dr. Rangaraj sir, and as well as speaker, and other speakers, Dr. Balamurugan sir, Dr. Meenakshi Sundaram sir, Dr. Lakshmi Narasimhan sir, Dr. Guhan Ramamurthy sir, Dr. Peri Karupan sir. So today's topic, it is very simple, and it's going to be a very practical approach, like how we are going to deal the day-to-day cases, and also the finally imaging, what we can do when and what to be done prescribed for imaging. So this topic is going to be one of the first of its kind, like we have dealt with in CGP. This is a little different topic, and hope it is going to be useful for every one of us. And other thing is, we are also going to inaugurate the course, Fellowship in Neurology, so which is done by course coordinator Dr. Balamurugan sir. So while inaugurating the session, as well as we are going to inaugurate the fellowship course, I request all our members to have a look on the modules. We'll have a presentation in between. So based on that, if it is going to be useful, kindly join. So joining the course is very simple. You need to be a member of IMA and also member of CGP wing. Thank you, sir. Over to you. And just before that, I'll just tell one more thing. 2 more days left for the registration. So we have close to 2,900 registrations. And apart from that, we have 1,500 members who are participated and not registered. In case you need credit hours, kindly register today and tomorrow. So once you have attended, kindly register. We'll be closing the registration tomorrow. Over to you, sir.
Thank you, Dr. Senthil. As I was planning to say some words regarding the course you have told already. So there are many courses being conducted by CGP, like all the participants, most of them know it. But this is the new course which is going to be inaugurated today. So it is office-based neurology for general practitioners. So when a patient comes with a headache or a LOC to a OPD to a general practitioners, how you approach that case. So the modules have been designed in such a way that it is useful for the primary care physician who can handle the first aid, and if necessary, he can refer the patient to a concerned specialist immediately. So the team who is going to conduct the course, that is the team which is conducting the CME today. So all the faculties who are going to be the part of the course are the faculties today. Most of you might be knowing all the faculties. So it's a star-studded faculty, and you can know the quality of the content from today's CME itself. So without wasting much of my time, I would like to welcome one more, the last speaker for the day, Dr. Peri Karupan, interventional neuroradiologist. He is going to speak upon what imaging when and for what case at last. So welcome, Dr. Peri Karupan. செந்தில் பெரிய கருப்பனையும் co-host பண்ணி விட்டுருங்க. அவர் ஜாயின் பண்ணிட்டு போட்டிருந்தார், மியூட் ஆயிருக்குன்னு, அது மட்டும் பண்ணி விட்டுருங்க டாக்டர். Okay. So now I hand over the proceedings to Dr. Rangaraj sir, one of our faculty, to take over the session and moderate the session. Rangaraj sir.
Good evening, sir, and thank you for the opportunity. And this is a different course, as Anand and everyone is telling. நம்ம எல்லாருக்குமே எம்பிபிஎஸ்லேருந்தே வந்து நியூராலஜி அப்படின்னா ஒரு பயம். எப்படி கேஸ் பார்க்குறது, நியூராலஜி கேஸ் வந்தால் நம்ம ஃபெயில் ஆயிடுவோமோ அப்படின்னு அது ஒரு பயம் எக்ஸாமில். ஸோ அப்போ ஸ்டார்ட் ஆனது இப்போ இருந்தே நியூராலஜி கேஸ் வந்துட்டு அடுத்த நிமிஷம் வந்து ஐயோ உடனே கிளம்பு அப்படிங்கிற மாதிரி இருக்குது. ஸோ அப்படி இல்லாமல் பேசிக்காக நம்ம பார்க்குறது வந்து பேக் பெயின், ஹெட்ஏக், sudden giddiness, sudden weakness. So what are the cases which we have to see? Initial, what are the tests to be done? Clinical in examination la enna paakano, enna investigation pannalam, and when to refer. This is the plan of this program. So please join us, and I welcome Dr. Balamurugan, our neurologist and the course director of this course from Salem. Balamurugan, welcome you, sir. He is from our Tanjavur Medical College and then from NIMANS, and wonderful speaker. And Tamil ஏகப்பட்ட books எழுதியிருக்காரு, headache பத்தி, Parkinson பத்தி எல்லாமே. So that will be very useful for most of our patients. And Balamurugan sir, you can start your speech.
Sir, sorry to interrupt, sir. Just a minute, sir. Our president, Dr. Sengatuvan sir, will be joining in another 5 minutes, sir. So, sir would like to inaugurate the course, and sir, as I think Balamurugan sir is very close to Sengatuvan sir. He would like to inaugurate, sir. You can just proceed, sir. Once he joins, I will just inform you, sir. Just he will inaugurate the course, then we will start, sir. Yes.
Introduce the course in between. So when sir comes,
You can. Yes.
we just introduce the course.
Yes, sir. Done, sir.
And is it slide is visible, sir?
Yes, sir. Visible, sir.
Okay. Dear friends, it's a great pleasure on behalf of IME and CGP to organize such a wonderful program, especially office practice neurology and emergency neurology for the general practitioner. The basic purpose of this course is to make neurological emergency simple, and when to see these patients, rarely you are supposed to refer the case. So the purpose is not to refer the case to the neurologist, to treat at your office. There may be some difficulties initially, because most of the time neurology is the one topic we skip, as Rangarajan was telling that. But today's, with the availability of the investigations and the clinical acumen that what you have gained over years in our practice, I'm sure at the end of this course, you should be able to make almost 90% of correct diagnosis at bedside, and then you can treat the patients properly. So with this in our mind, we started what is needed for the doctors. So the concept came over the last 25 years when freshers come to our casualty as a duty doctor. The difficulty is what they had, because in MBBS training, always it is a hemiplegia, paraplegia, syringomyelia, motor neuron disease. That is not your daily practice. Your daily practice are headache, vertigo, dizziness, back pain, neck pain, sudden onset of sometimes loss of consciousness. Those cases are not exam cases. So the freshers are not able to manage or recognize sinister problem in those cases. So we have to train them nearly for about 3 to 6 months. Then all the people who got trained by our hospital programs, hospital protocols, at the end they feel we are very good at neurological case evaluation, sir. So keeping that in my mind, so with the help of my colleagues, with like-minded people, we have started this. I'm sure this will be very useful. So the purpose, hello. One should be able to approach and manage neurological cases with confidence. And it is a structured, continuous education, converting a beginner to an expert. It is a case-based discussion. Clinical videos will be shown for easy learning. Algorithm for easy practice. You can paste in our OP room and then you can do tick, right? 1, 2, 3. Now it has become AI based. To have an AI based algorithm, we have to give inputs to the computer, isn't it? So that algorithm is with us. And if you join the course, if you have difficulties in the OPD you are seeing, recently one of our student called us that having an abnormal movement of this patient. So tongue is coming out. And so could it be seizure? Could it be extrapyramidal? So how to manage that? So he didn't refer the case to anybody. He managed advice online video. That is possible for those people who are joining the course because they will be knowing how to go with the algorithmic approach. And some of the PPT slides of the cases for the review will be given, and managing caregivers. That's the most important. Scientific pamphlets, as Rangaraj was telling that we have scientific pamphlets for the patient attenders. What is a stroke, what they should do, what they should not do, what is epilepsy. And in abroad, it is available online in, of course, in English language. In Tamil Nadu, in Tamil speaking people, they find very difficult to understand that. So all those things are in cartoon diagrams we have, and those things can be given to the patients and then say, this is epilepsy, this is a first aid you have to give, these are things you should not do. Who should attend? Freshers planning to start practice in rural area. General practitioners finding difficulty in neurological cases. Family physicians seeking update in neurological office practice. Emergency physician to get algorithmic approach to neurological emergencies. Young physicians to update essentials of neurological practice. And if you have passion in new learning. The research says that new learning prevents dementia. Course format is and the duration is 10 months. Once in a month, it's a hybrid. Total, we have planned 10 classes. So each session is about 4 hours, so 40 hours. We can have direct contact classes in Salem once in a month on Sunday. We will be providing lunch. And we are planning to make the last thing at the ERCOT with a mini conference for those people. Simultaneous Zoom transmission for distant learners. So in addition to that, twice in a month, only online sessions. So just for 2 hours. So total of 40 hours plus 40 hours, 80 hours of learning neurology. It will not be didactic lecture. It will be one-to-one interaction. We are planning to start in August and it will be over by March 2026. The practical exam will be in March 2026 or April. Convocation will be the next year. So the model 1 is bedside examination. You might have forgotten what to see in the neurological cases. So that will be given. And approach to facial weakness. And what you call fast, essential, and specific testing at bedside, what we call as a feast. And second model is a headache. We are going to give sample today just to taste how our course will be there, how it will be practice oriented or specific question oriented rather than didactic lectures. And model 3 is vertigo and dizziness. If a patient comes with a dizzy or vertigo, is it a stroke or is it a simple positional vertigo or is it a vestibular neuritis? Whether what we should do, ask for an MRI or we should go for a canalith repositioning, those things will be answered. All this repositioning maneuver will be taught you with the proper videos. And model 4 is coma evaluation in the emergency and approach to movement disorders and emergency movement disorders. Model 5 spinal cord and peripheral nerves. This is mostly for second or higher level people, but you should be able to recognize this as myelopathy. And this is most important epilepsy because most of the time the general practitioners who see more epilepsy than the super specialist. So they should be able to recognize the epilepsy. 40% of the epilepsy they can manage the village. When they refer, they don't go to the super specialist and they may go to the quacks. That's the thing happening. So I'm sure at the end of this course, all the MBBS doctor or the physician should be able to diagnose the seizure semiology, type of seizure, and necessary investigation and proper treatment also they can initiate. So some EEG basics, what is needed for them. Model 7 is stroke, 4 models for acute stroke management and thrombolysis. And thrombolysis can be done if you have a CT scan nearby. So, and how to identify stroke mimics and stroke chameleons. Model 8 is neuroinfections, very common in our practice. Is it a fever with headache is a systemic infection or is it a meningitis? That question always comes. How to identify those neuroinfections? What are the clues you get from the general examination? And a scar in one area can say it's a typhus, nothing but a fundus examination may give you a clue for you. This is probably viral or a malaria. So similarly, those clues with a good visual visuals, especially videos or pictures, will be shown to identify those cases. And suppose you suspect a neuroinfection, meningitis or meningoencephalitis, what you should start as a first time because it's an emergency. Later, you have to identify the organism. So, model 9 is neuroimaging. We have one of the great neuroradiologists, Dr. Periyakarpan. So, good interventional neuroradiologist. So, he'll be joining with us for CT scan reading and reporting basics. And sometimes the patients may be coming with CT scan report alone, or the CT scan film alone. So, you should be able to tell the basic things. And model 10 is miscellaneous, tropical neurology, neurological disease, or நேர் விருப்பம் மாதிரி அவங்க என்ன கேட்குறாங்களோ அந்த டாபிக் செய்யும். So I'll be the course director and the faculties are Professor Lakshmi Narasimhan from Chennai, the retired professor from MMC, the Institute of Neurology, and now he is attached with the Institute of Medical Sciences. And my good friend Dr. S. Meenakshi Sundaram from Madurai, my colleague in the MANS, and Gohan Ramurthy, the young, enthusiastic, energetic, and the most knowledgeable person from Tiruchendur, and our IME leader, Dr. R. Rangarajan, Hosur practitioner, a busy person, and the course director of IME CGP director, ENT specialist Dr. Anand Chakulingam from Ramanathapuram, all will be joining. And I'm sure that you'll be having a great experience in learning. Now,
Sir, thank you, sir. And we have our state president, Dr. Sengutun, sir, just joined. And we'd like to start to inaugurate the course, sir. Over to you, sir.
Thank you, Dr. Sendil. I'm really very glad that Dr. Balamurugan is going to take the essentials of the neurology and emergency in neurology. We have approached him during a conference and he readily agreed for this, and he also suggested that course to be conducted for 10 months. Dr. Balamurugan is a very good academician, very good clinician, and he is very active person in the neurology. He is a very good teacher, and he will explain everything in nice manner. And I am really very glad that essentials of neurology has come to our CGP fold. I hope after seeing this lecture, many of them will come over here and to join the course. Best wishes to the Dr. Balamurugan and his academic team. I'm here with inaugurating the course, Essence of Neurology and Emergency Practice. Thank you very much. Over to Sendil.
Thank you, sir. Thank you so much, sir. And I think we can move with the CME today. And I request Dr. Rangaraj, sir, to moderate the session and take over.
Yes, sir. I request our Balamurugan, sir, to start the first presentation.
yes, sir. So now you all know the model. This today is a sample. ரெசிபி ப்ரிப்பேர் பண்ண பிறகு வீட்டில் கொஞ்சம் சாம்பிள் கொடுப்பாங்க தெரியுங்களா, அந்த மாதிரி ஒரு சாம்பிள் தான். அண்ட் மை பர்சனல் தேங்க்ஸ் டு Dr. P. Senguttuvan, IMA President, National State President, because of him only, this particular chapter we could start as a neurological emergency. Though he said that they approached me Actually, I requested him, why can't we start from Salem? So he readily said that in my tenure, yes, I should do it for Salem member. So thank you, sir. Thank you for recognizing us. And I'm sure this will be one of the most wanted topic in the near future. So we'll start the program with approach to headache. You know, the headache may be first or new onset. That means patient coming to you with 3 days of headache, 10 days of headache, 1 month of headache, or headache may be chronic headache years together, and then they come to you with just 1 or 2 days of headache in the background of 10 years of headache. So today the topic is mostly we want to cover the acute headache. So nearly about 4% of our patients coming to emergency department are complaining of headache. Nearly 4% are vertigo. So you can imagine that 8% is vertigo and headache. So nearly 8 to 10% you can manage if you learn these two topics, which is not taught during our undergraduation. So which headache is dangerous? That's the question, that whether I should take MRI for all the patients. MRI may be normal in migraine. MRI may be normal in meningitis. Migraine normal, okay, you can take time. Meningitis, it's a costly miss, isn't it? Brain abscess, MRI will pick up, but meningitis MRI may not pick up. Subarachnoid hemorrhage, you may miss if you are taking a CT scan after 2 or 3 days. Giant cell arteritis, your MRI will be normal, CT will be normal, LP will be normal, but the patient will be having acute severe headache. So patient coming with headache, but it may be the head has eye, ear, nose, sinuses. So when they have headache, at least 3 departments is involved: ENT, ophthal, and because neck is there, orthopedician, and dental. So at least 3 to 4 departments in addition to our neurology. So how to deal these type of patients? The most common cause for acute headache in emergency is a migraine, but we are going to deal today new onset headache. First time they are coming to our clinic with just 2 days or 2 weeks or 1 month, less than 1 month, with no previous history of headache. So the approach is very simple. Our aim is to rule out sinister causes of headache. They call us SNOOP 4. Any patients with headache and systemic symptoms, fever, chills, weight loss, malignancy, known seropositive, tuberculosis, this group is entirely different. So they need an emergency evaluation. Yes. N for any person coming with neurological signs and symptoms, confusion, focal neurological. This Dr. S. Meenakshi will be covering this topic. And coming with acute onset severe headache, that I'm going to talk on this particular issue. Onset is thunderclap. What do you mean by thunderclap? Acute severe headache onset to peak within a minute. So I'm going to cover this particular issue. Patient coming to your OPD saying that லைஃப்ல இது மாதிரி தலைவலி இருந்ததே இல்லை, வாழ்க்கையில இது மாதிரி ஒரு தலைவலியே இல்லை, அந்த மாதிரி தலைவலி தான் thunderclap headache. So then senior citizen after the age of 50 coming to ongoing continuous headache plus or minus visual disturbance. Dr. Rangarajan will be covering this topic. And positional headache. So when they say that headache only on sitting, so probably orthostatic, especially after lumbar puncture, after spinal surgeries. So this is a positional headache, how to manage those. And another P is prior history with headache. So probably it's a migraine-like or ongoing headache with persistent headache, new onset persistent headache, and pregnancy postpartum. The most important thing, a lot of legal issues comes, and the most of the time in maternal auditive meeting, this discussion comes. How did you miss this headache? You should have asked for CT or you should have checked the BP. So Professor Lakshmi Narasimhan will be covering this topic. And headache preceded by Valsalva, coughing, sneezing. It means there is some rise in intracranial pressure. So you have to ask systemic signs, symptoms. Any focal neurological deficit is there? Onset, is it thunderclap or age more than 50, first time of headache, positional, prior history, pregnancy, placebo solver. These group need urgent evaluation. So now I go with my topic, person coming to ER with acute severe headache without any neurological deficit, no right side weakness, left side weakness, no diplopia. So onset is a thunderclap. What do you mean by thunderclap? Sudden severe headache, explosive, unexpected headache. The onset to peak severity less than a minute by definition. But patient நீங்க கேட்டீங்கன்னா ஆரம்பிச்சதுல இருந்து உங்களுக்கு பீக் போனது ஒரு நிமிஷத்துக்குள்ளார வந்ததா அப்படின்னு கேட்டா யாராலையும் சொல்ல முடியாது. யாரும் வாட்ச் கட்டிக்கிட்டு ஒரு நிமிஷத்துல போதான்னு சொல்ல மாட்டாங்க. இது வரைக்கும் லைஃப்ல இந்த மாதிரி தலைவலி இருந்ததே இல்லை சார். That's one strong clue because we all might have experienced headache in our lifetime. So we say that travelனால வந்துச்சு, sunlight exposure வந்தது, சரியா தண்ணி குடிக்கல. So all those things we know that type of headache. But this headache, they say that they immediately rush to the hospital. They know that the headache is very severe. That's the reason it's called thunderclap, like a thunder clap. So it's thunder sound. So acute severe onset to peak within a minute. It's a thunderclap headache. Common cause, somebody says that thunderclap headache means for MCQ purpose, it is subarachnoid hemorrhage. But if subarachnoid hemorrhage is not there, what are the other possibility we'll discuss. So for all practical purpose, இது வரைக்கும் வாழ்க்கையில இந்த மாதிரி ஒரு தலைவலிகள் பயங்கர சிவியரா இருக்குது அப்படின்னா it is thunderclap headache, so it is subarachnoid hemorrhage. So we have to go for non-contrast CT scan. So most of the time now the neurologists are very clear. They don't go for a contrast CT. They ask for a plain CT. Now 30 years before, why do you want a plain and then contrast go for a contrast CT? Because we used to see a lot of neurocysticercosis or tuberculosis. So plain CT and contrast CT costly, so they go for a contrast. Now we are very clear, go a non-contrast. If you go for a contrast CT, the vessels will be enhanced, that causes confusion. So ask for a non-contrast CT. Non-contrast CT clearly says blood in the subarachnoid space. Clear. Thunderclap headache is due to aneurysm rupture. Suppose it shows some other things. It is not subarachnoid hemorrhage, something else possible. Though thunderclap headache is equated with subarachnoid hemorrhage, it's not always. Thunderclap headache is the classic for subarachnoid hemorrhage. It's not the rule. So suppose CT scan is normal. You have done a CT, you suspect subarachnoid hemorrhage, normal. Your suspicion is subarachnoid hemorrhage, you can go for LPCSF analysis. So all thunderclap headache, you should rule out this because CT may be normal if you do second, third, or fourth read, or minimal subarachnoid hemorrhage be normal. So CSF will give you a clue it is a subarachnoid hemorrhage. Or sometimes CSF may give some other clues. You may be suspecting subarachnoid hemorrhage and it may show you pyogenic meningitis. So then they say that, yes, doctor, yesterday night mild fever, especially extremes of age, kids may suddenly develop acute pyogenic meningitis. They won't give time. And it may be trauma. If it is gone in the CSF, you tried that it became a traumatic. So these are all the problems that you can have that. CSF is also normal. Then still your suspicion is thunderclap headache, then you have to go for MRI, MR angio. MRI may pick up subarachnoid hemorrhage, or it may pick up the aneurysm also in MR angio. So till now we have not used the contrast. There's no need of contrast. MR angio doesn't need a contrast. So another advantage of MR and MR angio is that if it is not subarachnoid hemorrhage, not aneurysmal, it may give some other clue for causes for thunderclap headache. So I said that thunderclap headache, subarachnoid hemorrhage is the typical, but it could be due to sometimes carotid artery dissection, vertebral artery dissection, cerebral venous thrombosis, reversible cerebral vasoconstriction syndrome. These are the other possibilities. So vascular imaging will give you the idea. That also turns out to be normal. Okay. Sometimes spontaneous intracranial hypotension, if you have not put the history very clear to the radiologist, it may be missed. So pituitary apoplexy, cholestasis in the third ventricle, it will not be missed by the imaging. Acute hypertensive crisis. These are the things, even your MR angio may be normal or may be less normal. So I think We'll go with a case. This is a 60-year-old lady. Sudden first episode of severe headache. And she could say that with vomiting. So she had holocephalic pain and neck pain, just 2 hours duration, with vomiting 3 episodes. Patient was conscious and BP was normal and GL. So BP is not normal, 180/100 is normal. Generally in practice, any patient coming to the headache and BP 140/90, your BP is high, you are having headache. No. To produce headache, the diastolic BP has to be more than 110. I repeat, to produce headache, the diastolic BP has to be more than 110. So 130/90, 140/100, 160/100. If the headache is there, patient is having high BP, but that is not causing the headache. So this is a common error in practice people do, and we get reference. The doctor said that BP scan next day the patient found unconsciousness. So this happens when you want to say the BP is a cause for acute severe headache. If the diastole is more than 110, without focal neurologic deficit, you can say that. Otherwise, we have to be very cautious in blaming the BP. So this patient had a CT, plain CT, which showed you can have hyperdense in the sylvian fissure. So it is obviously subarachnoid hemorrhage here is also there, but it's more here. So probably middle cerebral artery. The radiologist can give you a clue that it is an aneurysmal bleed, probably middle cerebral artery because of the left sylvian is there. And the blood has gone into the ventricle also. You can see here the blood in the ventricle. So sometimes this alone may be the clue. This all will get disappear on second and third. An astute radiologist will say that, sir, the first view was normal, but I could see carefully just 1 ml of blood in the occipital horn of the ventricle. Probably this person having intraventricular bleed. So that's a clue that. So this MR angio itself could say that there is an aneurysm here. But once you suspect aneurysm, you have to hand it over to the interventional radiologist or neurosurgeon. Clipping or coiling has to be done. They will be planning for CT angio or DSA. That part we have to give respect to that field rather than spending time or wasting time. So once it is a subarachnoid hemorrhage, yes, then this patient has to move. So if subarachnoid hemorrhage is not there, an MRI may give you all other possibilities. Here there's an aneurysm, this patient was operated and the patient improved well. So the classic pattern of subarachnoid hemorrhage is a sudden development of a severe headache, often referred as the worst headache of life, thunderclap headache, usually associated with any sudden bleed in the subarachnoid space. Meningeal irritation may cause meningism, nausea, vomiting, altered mental status, loss of consciousness, seizure or seizure-like events, or acute focal neurological deficits. That happens usually about 48 to 78 hours because of the vasospasm. So again, for the general practitioners, what I want to emphasize is that the young practitioners or duty doctor coming, patients in the nausea, vomiting on this, and pantoprazole கொடுத்தேன். அதுக்கு பிறகு ஒரு 2 hours கழிச்சு patient fit வந்துருச்சு. What else the patient had? Headaches. So a GI problem will not cause headache. This most important practical point, take it from me. When the patient says headache, vertigo, nausea, vomiting, it is not from the GI. So the headache can produce vomiting, the vertigo can produce vomiting. Very simple clinical clue. Because why I'm stressing this, said, doctor, we know this point. Why I'm stressing this is the most common mistake done by duty doctors. So after 12 hours, we see patient coming in the night 10 o'clock. So we had given pantoprazole and on them. What happened? Next day morning found unconscious. What else the person had? Nausea, vomiting and headache. So because nausea, vomiting they have seen patient vomiting. So importance was given for that. So acute peptic ulcer patient coming at night 9 o'clock, 10 o'clock with headache. So that's the most important thing. So headache has to be viewed as a headache as a brain problem. So acute severe headache with no other neurological deficit. Whom should we screen for subarachnoid hemorrhage? There's a rule, Ottawa subarachnoid hemorrhage rule is a decision rule validated for use in the emergency department to screen for subarachnoid hemorrhage in patients with acute headache who are neurologically intact. If the patient has neurological deficit, okay, you know that you have to go for imaging. Implementation of the Ottawa SAH rule in practice has reduced the total number of lumbar puncture done while retaining 100% sensitivity for SAH. Otherwise, you will be keep on doing all the patients. CT normal, go for a LP. Then LP normal, we can't keep going that. Investigate if one or more of the following high risk variables present. One or more than one. Onset during exertion. வேலை செஞ்சிட்டு இருக்கும்போது ஆச்சு. ஸோ வயலில் வேலை செஞ்சுட்டு இருக்கும்போதோ அல்லது வந்து மாடிப்படி ஒரு வெயிட் தூக்கிட்டு போயிட்டு இருக்கும்போதோ வந்தது அப்படின்னா. Thunderclap headache. Onset to peak is within a minute. Tight neck. After the headache with the tight neck. The headache with the tight neck can happen in acute migraine, but that will be very severe. Okay. And age more than 40 or more than 40. Witnessed loss of consciousness. And a sign, limited neck flexion on examination. They are not able to do flow. So this is called Ottawa. Any 1% is you are justified to go ahead with thorough evaluation of subarachnoid hemorrhage, CT, CT angio, or LPCSF. What is the best modality of imaging? As I told, the preferred modality is a non-contrast CT brain. So it's available in Tamil Nadu. Almost each and every district, every village also started having non-contrast CT. I think that when I started practice 30 years before, so CT MRI was available from Salem. Next was in Pondicherry. This side next was in Bangalore. Now we are having the Attur, we are having it Rasipuram, we are having it Namakkal, we are having this side at Mallu. So everywhere. So every 20 kilometers we have CT scan. So this is the best modality, easily available, and you can do it within 5 minutes. It's the most sensitive for subarachnoid hemorrhage in the first 6 to 12 hours. Following aneurysmal rupture, they are sensitive about 93 to 100%. Diagnostic sensitivity by head CT degrades over time, declining to 60% at the end of the post subarachnoid hemorrhage. So it slowly comes down. So we have to be careful. At the end of 7 days, just it drops to only 60%. I think that most of the patients come within 1 or 2 days. So in the first 6 hours of subarachnoid hemorrhage, so I put specifically first 6 to 12 hours, the best is most of the time the patient come within few hours. By the time you plan for CT scan, it will come around 6 to 12 hours. So I prefer a CT, a non-contrast CT, the first when you are suspecting subarachnoid hemorrhage. Suppose you reach you are contemplating with a CT or MRI patient score not irritable. MRI may be slightly superior to CT. This is a new arrival in the imaging modality, especially when you have a bleeding recalled echo, susceptibility weighted imaging, or flare sequences. The radiologist can pick up subarachnoid hemorrhage. In addition to the subacute and chronic phases, in acute phase also can pick up. And confirmed SSH. Is it aneurysm or non-aneurysmal SSH? How to proceed? So you have done an LCT, which is subarachnoid hemorrhage, or you have done an LP, which has shown is a subarachnoid hemorrhage. How to proceed? So for general practitioners, physicians, this is a time that this cases has to be referred to a team of neurology, neurosurgery, interventional radiology. We generally proceed with CT angio. So if no contraindication, especially creatinine has to be looked. Even if the creatinine is 4 or 5, if there is subarachnoid hemorrhage, we have to explain to them, and then we can go for dialysis after this contrast, because this is a life-threatening. We have to go for clipping. CT angio has 90% to 97% sensitivity in detecting an intracranial aneurysm compared to digital subtraction angio. DSC is the gold standard. Sometimes CT angio is inconclusive or it's doubtful aneurysm, then we go for DSC. A negative CTA is insufficient to rule out the presence of a bleeding aneurysm in patients with aneurysm SAH, particularly when the bleeding aneurysm is smaller than 4 mm. So there's one caveat here. When cerebral aneurysm are detected on CT angio, patients often still proceed to DSC, which is also a potential therapeutic modality for endovascular treatment of the bleeding. So they're not going for endovascular, then you can give it to the surgeon who wants to go for clipping. Non-traumatic subarachnoid hemorrhage. Yes, it is subarachnoid hemorrhage, but not aneurysmal. Is it possible? Yeah, it could be mesencephalic subarachnoid hemorrhage. It generally has a good prognosis, 1/3. Among the mesencephalic also, we recently read a paper around 10 to 15%. If you do CT or CT angio later, you can pick up the aneurysm. It's not like mesencephalic subarachnoid hemorrhage is equal to non-aneurysmal. And among the 20% of the non-aneurysmal, AVM is also a possibility. So, role of LP in suspected subarachnoid hemorrhage. If you have a CT, obvious subarachnoid hemorrhage, what do you want? Why do you want to do an LP? No, never do that. In case of negative or equivocal imaging, but high clinical suspicion of subarachnoid, that's we said the Ottawa rule. You can apply the Ottawa rule. The classic diagnostic criteria is presence of xanthochromia. So we can do that. Nowadays, we almost stopped doing LP for subarachnoid hemorrhage because we have a very good imaging modalities. So subarachnoid hemorrhage you are suspected and you are managing your nursing home. You have called the surgeon or you have called the interventional radiologist. Sometimes they can present the cardiopulmonary arrest. So just brought dead or brought in the peri-arrest. But they say that எந்திரிச்சாரு ரெஸ்ட் ரூம் போயிட்டு வரும்போது தலையை வலிதுன்னு சொன்னாரு, அப்புறம் வாந்தி எடுத்து அப்படியே கொலாப்ஸ் ஆயிட்டார். ஸோ தலையை வலின்னு சொன்னாரு, அப்புறம் வாந்தி எடுத்து கொலாப்ஸ் ஆனார். திஸ் இஸ் a very classic for probably subarachnoid hemorrhage, and then they had a cardiac. These are the cases branded as sudden death, probably cardiac event. That means coronary artery disease. No, whenever there is a headache, it has to be from the brain. So we hear stories of so and so died suddenly. Then we ask the history. No, he was in the restroom and he came out with a headache and then he vomited and collapsed. It's very classic for straining, rupture, and then they can have a cardiopulmonary arrest. Not all subarachnoid hemorrhage, all bleed in the brain give time. Generally, they give time, but it can happen in SAH rather than in intracerebral hemorrhage. Cardiopulmonary arrest is well-known phenomena in subarachnoid hemorrhage. They may present with milder initial symptoms, but then acutely deteriorate, often because of aneurysmal rebleed. A rebleed risk is nearly about 8% to 25%. It's highest within the first 72 hours. Or they can develop acute hydrocephalus because of blood going into the ventricle, blocking the pathway at the third or ventricle or fourth ventricle outlet, or in the ultimately it goes to the basal area, so that can produce hydrocephalus, usually second or third day. So deteriorating fast, it could be due to rebleed, it could be hydrocephalus, or third, fourth day, it could be in infarct development. Within the first week of SAH, up to 30% may develop cardiogenic shock, cardiomyopathy. So sometimes we see that operation success, patient failure on third, fourth day. So suddenly they develop cardiac failure. So have a watch about the Takotsubo cardiomyopathy. So cardiologists can make a clear diagnosis of the echo finding where the LV apex is ballooned out. So that's very classic. They may have an ECG finding like an MI, but it's classically Takotsubo cardiomyopathy. QTC prolongation followed by deeply inverted T wave. This is called cerebral T wave. So sometimes when you show the ECG alone, people say it's probably subendocardial infarction. A deeply inverted T wave. It's a cerebral T wave, and that can happen in subarachnoid hemorrhage. Troponin elevation may be seen in 30% of the patients with SH. Now we understand cardiopulmonary arrest, T wave, troponin elevation, echo showing cardiomyopathy. So this is one presentation in ICU. We had to be very careful with headache. So with this, I stop discussing about this particular topic, and I hand over to the moderator, Dr. Rangarajan. He'll be proceeding with the next speaker. Will be talking. And any doubts regarding this, I'm ready to clear right now. So the topic for me is acute severe headache in our practice. suspect subarachnoid hemorrhage, rule out subarachnoid hemorrhage. All other causes for acute severe headache has been discussed. Subarachnoid hemorrhage suspected, what you should do, and what are the complications you have to expect in your nursing home. Thank you.
Thank you. Wonderful presentation, Bala. And actually, they have unmuted everyone, so they can put whatever the questions in the chat box, so we can respond to that. The participants, please, whatever the questions, you can put it in the chat box and we can answer them.
Yes, sir. Sir, I think as of now, there is no questions, sir. We can just keep collecting the questions and we will have it at the end of the session also, sir. That will be easy also, maybe. Yes, sir.
Rangaraj, nearly 850 participants has joined. That's amazing.
Yes.
In any conference, we are not seeing more than 50 people, isn't it? So any conference, even to the national level, we see maximum over 100 people sitting in
100
the...
100
is the maximum. Now you could see that 833
35, 835 now it is.
Yes, sir. It will be little increasing also, sir. I think around 5:30 it will increase also.
The IMA, and my special thanks to the IMA president, Dr. P. Sengitun, sir. Thank you, sir. Next.
Sir, there's one question, sir. There's one question. How
Next
do we differentiate? Sir, there is one question, sir.
Yes, sir.
Can we just explain this, sir? Like first line medicines to be started on suspecting SAH.
So suspecting SAH, if the pain is severe, you can give Phenergan, injection Phenergan. So it takes care of vomiting, headache, and it makes the patient little bit of sleepiness also it induces. Or you can give Emisset to prevent the vomiting. Then you can hydrate, they call triple H, good hydration, and you can give steroids and nimodipine. So 60 milligram, that is available as a 30 milligram tablet. So 60 milligram, 4th hourly or 6th hourly, you can start, and you have to confirm it. So these all things has to be started. And if your suspicion is high, anticonvulsants are allowed. We can give anticonvulsants. There are two areas where we give anticonvulsants prophylactically. There is nothing called prophylactic anticonvulsants in general practice. But when you are suspecting CVT and subarachnoid hemorrhage, you are justified in starting prophylactic anticonvulsants because one seizure may deteriorate the patients very badly.
Thank you. Very, very nice presentation, Dr. Balamurugan. Really, I'm thanking you for your nice presentation. Thank you.
Another one question, sir. One is how to differentiate subarachnoid from cluster.
Yes. Subarachnoid hemorrhage is bilateral and it will be diffuse and it will be neck. Cluster headache is what you call as it unilateral, side locked. So suppose the cluster headache comes the first time. So cluster headache is known as episodes. It comes repeatedly. They may be coming on the third attack, fourth attack. But if they come on the first time, it follows the V1 distribution. It exactly retroorbital. In addition to that, we call this cluster headache comes under the TAC, trigeminal autonomic cephalalgia. They may be having redness of eye, lacrimation, and the same side nose there may be nasal discharges. That means especially rhinorrhea, not the pus discharge, rhinorrhea. So lacrimation, because of the autonomic dysfunction, they may be having a red eye. So people may get confused with glaucoma. Of course, glaucoma has to be ruled out. Sometimes they may go to the ENT because there is a nasal rhinorrhea, and in addition to that, they have pain in the V1 distributions. So it is side-locked V1 distribution, retroorbital pain with autonomic dysfunction. So that's classic for cluster headache. If you suspect cluster headache, the abortive things could be you can give oxygen, 100% oxygen, 6 liters per minute for 20 minutes in sitting posture, or you can give short course of a steroid. And again, you have to confirm a cluster headache. That means structural causes for headache has to be ruled out if it is a first attack. Always the cluster headache comes the same side. Even 10th time coming at the end of 5 years, it is side locked. Rather than saying the unilateral, it is side locked. Yes, sir.
One more question is when to repeat the CT scan? If first is negative.
If first CT is negative, if you are done within 6 hours, theoretically we can repeat, but most of the time we don't do within 6 hours. You can go for an MRI rather than repeating a CT scan. So we do repeat CT scan when we want to see that whether the person had a hydrocephalus, or sometimes if the person developed an infarct, we repeat it later on. But to diagnose subretinal hemorrhage, if the CT is normal, don't repeat the CT. You can go for CT angio or MRI with MRI angio, vessel wall imaging.
I think that's all the questions. And if anything is there, we'll do it in the last panel.
Yes.
And I think SMSR is on the line. So he had sent a message whether he can present.
Sure, you decide. If he is ready, then you can go ahead with it.
Okay.
So he is on acute focal neurons, next topic. Yes.
Yes.
Next is on. Yes, sure. SMS, you can share your slides. SMS, you can unmute.
I think we have to make him as a co-host.
So any organizers here? Can you make Meenakshi Sundaram sir as a co-host?
Sendil, kindly make SMS sir as a co-host, Sendil. Sendil, are you online?
I don't think he's online.
Okay, sir. I'll call him and tell him immediately. No problem.
So Dr. Meenakshi Sundaram is MBBS.
Started.
Yeah. So it's a great pleasure to introduce Sundaram. We call him as SMS. So he did his MBBS at Madurai Medical College. So you know the name Meenakshi Sundaram from Madurai. And then MD at Jaipur. Then DM Neurology at NIMHANS. Is a medalist in general medicine and also in DM Neurology, NIMHANS. He's an astute physician and a neurologist, and he is our encyclopedia for most of the neurologists of his age and the younger age. Welcome to Meenakshi Sundaram. The laptop is yours, Meenakshi Sundaram.
Thank you, Balu. Can I start? Am I audible, sir?
Yes.
Thank you. Thank you very much. So at the outset, where is this? Yeah. Thank you, Dr. Balmurugan, my guru, the course director. Thank you, IMA. Thank you, Ragaraj. It's a pleasure seeing you after such a long time, really. And amazing crowd. Thank you very much, IMA, for giving me this opportunity. So my case is quite short. It is a 17-year-old lady who presented with severe headache, which she described as the most severe headache ever. She described as a thunderclap headache, which Dr. Balmurugan just highlighted. This was noticed by her at 3 p.m. She was climbing a hill to reach a temple when this started. Severe headache. So she couldn't proceed further. She required support for walking. She developed severe giddiness and she was brought to a practitioner. She received some injections. We do not know what they were. Subsequently, she was noticed with some sleepiness. She was taken home and made to sleep. She did not have any improvement further. She was taken to a general practitioner. Headache was still severe for her. She could not even walk. So she was carried there and given IV fluids. Then she was taken back home. The family did not consent for admission. Went back home. At 3 a.m. in the morning hours, as she tried to get up and go to the toilet, she just couldn't get up. And that's when the family realized that she has developed dense weakness on the left side. Headache had now subsided completely. And now she was seen somewhere and brought to our hospital. She has been reporting headache on and off earlier for about a year, precipitated by lack of sleep or stress. And she used to take Dolo and Dolapar at the time to get relief from the headache. She used to sleep off and she used to become better. She never thought it was important enough for her to take any consultations anywhere for the same. So she did not have vomiting. She did not convulse. She had no ocular, visual, bulbar, sensory, or sphincteric disturbances. She did not report any history of trauma, fever, ear discharge. There was no past history of diabetes, hypertension, or cardiac disease, no stroke in the past, no addictions, no drug exposure of recent nature, no toxin exposure. Family history was significant. Her mother, her aunt, and an elder sister had been treated for recurrent headaches One of them had got a CT scan done that was apparently normal. There was no other family history of any significance, no stroke in the family. On examination, her vital parameters were stable. She had no meningeal signs. She was conscious. She was alert. Normal language functions. She had left upper motor neuron type of facial palsy. And there was no optic fundi were normal. Motor system, left hemiplegia, left hemihypoesthesia. One finding in cranial deficit I have not shown. I'll show it later on. Deterrent reflexes were brisk on the left side. Left plantar was extensor. The very important garden type of hemiplegia. That's what she came to us. So in a nutshell, this is a young lady with a syndrome of stroke in young. She had preceding thunderclap headache. There was past history of headache, which had not been evaluated. She had negative family history of stroke, but there was positive family history of headache. So Dr. Balmurugan just highlighted about subarachnoid hemorrhage, the thunderclap. Subarachnoid hemorrhage is a prototype thunderclap headache, but then we can have other etiologies also, one of which is reversible cerebral vasoconstriction syndrome. We are going to have a class on that subsequently. But there are other less common causes also. For example, cerebral venous thrombosis is an important etiology for thunderclap headache. Posterior reversible encephalopathy syndrome, just hypertensive crisis, carotid dissection, meningitis, spontaneous intracranial hypotension, and sometimes ischemic stroke and hemorrhagic strokes per se can present as thunderclap headaches. Rarely, pituitary apoplexy, aortic dissection, pheochromocytoma, choroid cyst of third ventricle, these are all other etiologies of thunderclap headache. So, thunderclap headache is not a sine qua non for subarachnoid hemorrhage. That's the message of this slide. So, we had a few differentials in our mind. Is it a complicated migraine? The headache was very severe in that migraine attacks that this lady thought it was actually a thunderclap. But then she had developed deficit subsequently. Is it some complicated migraine? Was it a cardioembolic stroke? Remember that many mitral valve diseases, PFO, all of them can have associated headaches as well. They can also have migraine. Migraine is such an innocuous thing in our so-called innocuous thing in the community that the prevalence may be high, especially in young population, that there may not be really an association. It may be just a coincidence of two important conditions. Was it some vasculitis which was presenting like stroke, and the neurological complication was a picture of systemic vasculitis? Or did this girl have AVMs in the brain and that was what has bled? Or was it some underlying tumor which was hitherto undiscovered and had hemorrhaged? Or the headache and the progressive worsening, rapid worsening also made us think that are we dealing with actually cerebral venous thrombosis or any other diagnosis? But then when as we ran through our differential diagnosis in our list, one thing was clear to us that when she came to us, the headache had significantly become less. So probably it was not CVT, there was something else going on. So the initial investigations appeared unremarkable. I request the audience to jot down your diagnosis, which you might have picked up. Just pen your thought in your paper and we can just come back to your diagnosis in the next couple of slides. So that was the MRI of this person. You can see the diffusion weighted imaging and the ADC map, which shows a sizable amount of infarct involving the gangliocapsular region. Quite a large infarct, you could see that. A very acute infarct. And on the left top corner, you could see that the flare changes have already appeared. We were not going to thrombolyze such a patient. And when we did the MR angiogram, in addition to the large nature of the infarct, what was obvious is the involvement of the internal carotid artery. You could see on the left side a very nicely seen left carotid. As you can see on the right side, there is absolutely loss of carotid signals. There is no ICA. All you can see is the two beautifully seen vertebrals and the basilar. You could see the left ICA. You can also see the left ECA, but not the ICA. It was a large vessel stroke sitting right in front of us. So the family did not consent for CT angio. We proceeded with neck vessel Doppler. It concluded our thinking that it was a carotid occlusion. But the eternal question we ask is that why did this patient develop IC occlusion? Was it pre-existent or was it a new onset occlusion? Is it some vasculitis? Is it an arteriopathy? These were all the thoughts that were going through our mind. So we try to look for the links between migraine and stroke. It has been known that migraine can be associated with stroke, especially those who have migraine with aura. Very rarely, you may have a patient who has migraine without aura, who also has focal deficits. That can be a cause, but such a dense involvement, an ICA involvement is very exceptional for this condition. So, though we were running through our mind this etiology at the end of the history, the imaging was not favoring this diagnosis. Oral contraceptive pills, it's commonly used in young people for regulation of their menstrual cycles. Estrogen containing pills can sometimes be associated with migraine-like changes as well as stroke-like presentation. So it's one thing we have to remember when we are prescribing these medications, especially for young people. And the same analogy holds true for people who are being prescribed OC pills or estrogen containing agents in their postmenopausal phase as well. Of course, in males, smoking is a risk. We saw that the association of petanforamin ON exists. Many medications which are used in migraine, the ergots, the triptans, because they are non-specific in their nature, they can produce vasoconstriction. One drug which has come as of now recent to the market, which does not have this vasoconstrictive property, is lasmiditan, the D-tans, because they act selectively on 1F. They do not touch the D. And there are genetic diseases which we consider as a link between migraine and stroke. The typical example is CADASIL, the cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, the HERNS, the hereditary endotheliopathy with renal, with retinopathy, nephropathy, and stroke-like episodes, and the mitochondrial syndrome, the MELAS, mitochondrial encephalopathy, lactic acidosis, and stroke syndromes. These were things which were running through our mind. And then there was a careful look which we had at the MRI, the MR angiogram. And as you look at the angiogram, you could see this important thing. Is my cursor visible, Balu?
Visible.
My cursor, you could see this area, which is the takeoff of the ICA. You can see inside the ICA a dark structure which is going through the ICA. That gave us a clue. And as you could see this, when you look at that part and then take a cross section of that area, now you can see this is the vessel and you can see a flap in between. And this is probably the intramural hematoma. And that flap gave us a clue that we were actually dealing with a dissection case. So this is a typical dissection. This is not a representative picture, but this is what that girl had. So I had to actually put it across. If you could see the clinical clue, though the pupils are not constricted, they are a little dilated in this image, but nevertheless you'll be able to appreciate that the right pupil is smaller than the left and there was ptosis in this patient. It was a clear-cut case of Horner syndrome. For the postgraduates who are looking at this place, this is a different case, not this case. But here you could see the Horner syndrome more typically in this patient. You could see the upper and the lower eye liptosis. Horner syndrome can be seen in dissection cases around 25%. Now, this is because of involvement of the oculosympathetic fibers. That is the whole pathway of the sympathetic chain starting away from the hypothalamus to the cervical ganglia, that is a first order neuron, and then the second order neuron going towards the inferior, middle, and the superior cervical ganglion. And from here, the third order neuron emerges. And you can see there are two pathways here. One passes along the internal cerebral artery, and that is the one which gives the oculosympathetic fibers responsible for the Horner syndrome, which we saw. The other pathway goes towards the face, It is responsible for the facial sweating and vasodilation. Therefore, the Horner syndrome of dissection is likely to be partial in nature, in which we'll have only ptosis and meiosis, but not facial anhydrosis. It's a very important clue. So this is the cranial nerve deficit which I failed to give you during my presentation. The simple message is that if a person has got Horner syndrome on one side, say right side of this patient, and has got a weakness on the opposite side, right Horner's, left hemiplegia, always think of dissection. So dissections could be spontaneous or related to trauma. When we think of trauma, we always think of very severe traumas. For example, we think of conditions like a penetrating injury or severe neck manipulation, what is done in chiropractic manipulation. Today, we can see many cases being brought to us courtesy of our barbers to whom our patients go when they develop neck pain. But then remember that it is not necessary that they should always require such severe manipulations. Trivial sport injuries have also been associated with dissections. For example, tennis, weightlifting. These sports have also been, in addition to other, dangerous sports or when exciting sports like scuba diving and all. Even horse riding has been associated with dissection. Remember all these things. So you do not rule out an etiology of dissection just because the trauma appeared trivial to you. Our teacher from Madurai, Professor Dr. Jayakumar, used to teach us that children, please do not give to their hand these pencils, because young children put the pencil in their mouth and that can go and cause a carotid dissection. So all these things are different. Spontaneous dissections are well known to have been associated with conditions like fibromuscular dysplasia, Marfan syndrome, Ehlers-Danlos syndrome, homocystinuria, and so on and so forth. So how does this dissection happen? This is the vessel wall you could see here that contains the interelastic lamina, the tunica media, and the tunica externa. When you look at that, there are several types of dissection. The common one is the dissection which happens in the tunica intima, which was happening in these patients. You can see the dissection moving on, creating a false lumen, which was what's seen in the image which I just showed. And then the image goes on to either occlude the vessel completely, or more commonly, a thrombus forms distally, goes and occludes a distal vessel, which is a common mechanism for stroke related to dissection. Sometimes you can also have subadventitial dissection in the outer wall when there will be an outpouching which can form an aneurysm-like structure, and that dissecting aneurysm can actually result in local complications, for example, pressure effects on various cranial nerves in the neck. So that was a subintimal dissection with a flap you could see here, which was responsible for the stroke in this patient. 36% of 333 cervical artery dissection patients had a lifetime history of migraine, versus 23% of healthy control. That was almost a twofold increase. Unclear if there is a mutual arterial pathophysiology, because after all, migraine has also got a vascular component, and dissections also have an endothelial vascular component. Simply because of inherited susceptibility being concomitant, is it the reason why migraine is producing dissection? This is a theory which has been floated. Until now, we don't have proof for this. So pain in the ipsilateral neck, face, or head is a common feature of dissection. 21% with carotids and 50% with vertebral artery dissections have this symptom. Ipsilateral Horner syndrome is seen in 40%. Headache or neck pain precedes the onset of ischemic symptoms, as was seen in this patient, by hours to days. Headache is present in 60%. They occur more frequently in patients with a history of migraine, although typically the headache experience and the type of dissection is not migraine-like, which was a classical percentage in this patient. It differed from the migrainous headache which she used to have earlier in being of thunderclap nature. The treatment always debated whether we should use antiplatelet or anticoagulation. There was a lot of emphasis on using only anticoagulation for these patients. But today, whatever data we have, the two important trials which we have, the CADIS data and the TREAT CAD data, say that antiplatelet and anticoagulation are just the same. How long we give this? It is still recanalization, which takes roughly about 3 to 6 months. and you do re-imaging at the end of 3 to 6 months, and then you can stop the anticoagulation of antiplatelet. No need to continue them continuously. The recurrence risk is about 3% for carotids and 5% for vertebral, a very small risk. The family is always afraid until you discuss this small risk with them. So prophylactic therapy of migraine with aura may be beneficial to prevent a migraine or stroke. So that is well known. We use drugs like verapamil, or we can use drugs like flunarizine. We do not use drugs which can precipitate vasospasm. Importantly, in these cases, do not use ergoids or triptans. So migraine can be associated with dissection. Dissection is the cause of thunderclap headache. Ipsilateral honor plus contralateral weakness, always consider dissection. Dissection treat with antiplatelet or anticoagulant. Thank you very much for the patient hearing.
Chat box, as you told, there is one question: is could it be a hemiplegic migraine?
Yes, sir. Hemiplegic migraine is one of the differentials in this case. Absolutely correct, sir. In those cases, many times we get family history, and that's a genetically mediated phenomenon. Obviously, it can happen. That is one another differential diagnosis we need to consider. Perfectly correct, sir. Thank you very much for pointing that out. Lakshmi Anna has joined. Anna,
Lakshmi sir, good evening.
Professor Lakshmi, to unmute, please.
any other questions?
There is only one question in the chat box.
So, and the people coming to hockey nickel, and the oil massage is one more cause for dissection in our area.
Absolutely.
One more question: sumatriptan for migraine and beta
Rangarajan
blockers.
sir, there is
for
a question. Rangarajan sir, in the meantime,
Yeah, Ellen, we are able to hear you. We can.
the question.
Sir, can I share the screen, sir?
Sure.
Sir, start பண்ணுங்க.
Any other questions, Anna? Anna, welcome. Balu, any other questions, Balu?
Is my screen visible, sir?
Yes.
Yes, sir.
Yes, sir. Yes, sir.
Rangarajan, introduce பண்ணுங்க sir.
Sir, we welcome Lakshmi Narasimhan sir, retired professor and now head of Department of Neurology, Ramchandra Institute of Higher Education, and a senior from my MD days, DM days, and my assistant professor, and then now professor. Sir, welcome, sir.
Thank you so much. Actually, sir, I'm extremely happy to be among all of you. I've never, as Balamurugan sir said, I've never seen such a big crowd. And 900 practitioners sparing their valuable time. I'm indebted to the IMA and the GCP for giving me this opportunity. And I'm thankful to my brother Bala and my very close friend Dr. Rangarajan for this. Thank you. So let me take you to this scenario. There are two scenarios which I'm going to discuss with you. One is a primary 19 weeks developed headache, bifrontal throbbing, lasting for the last 24 hours. She has been having nausea for the last few weeks. She used to have similar headache, not as intense before her pregnancy. And she had similar severe headache 4 days back as well. The second scenario is a 30-year-old woman who came to the ER with acute severe headache on the third post-operative LSCS, no neurological audio. These are the two scenarios which I'm going to first approaching the first case. See, in general, in pregnancy, the green flags are the current headache has been present for a long time, since sometimes in the childhood. Patient in between the attacks, patient has headache-free days. The headache occurs in temporal relationship with the menstrual cycle. Close family members have similar type of headache. Headache occurred or stopped more than 1 week ago. So these are certain green flags and headache when you come for starting. So this means these kind of headaches are essentially primary headache. What are the primary headaches in pregnancy? As you know that international headache classification, the three things are divided as called as primary headaches, where one is the migraine, the second is the cluster headache, otherwise the trigeminal autonomic cephalalgia, and the third is a tension type headache. So if you look at these are all the headaches in pregnant women, all these things, you can see the various types, starting from migraine with aura. Migraine without aura constitutes about 19.2, tension type headache about 12. All other things like intracranial hemorrhage, cerebral venous thrombosis, I'll come back to them later, but just remember that this is a major chunk of the headache, which are primary headaches occurring in pregnancy. The secondary headaches which are very specific to pregnancy, I'll talk to you later. So among the three primary headaches, the migraine forms a major thing, and the next second common thing is the tension type headache, and the third is the other primary headaches. So if you look at migraine, how does it behave in pregnancy from the pre-pregnancy level? Just look at this graph, you will understand that it can run for a peak during the first trimester, then very quiescent, and then further go down in the third trimester, and the second peak happens in the puerperial period. This is one type. There are three types how migraine can behave in pregnancy. This is the first type. The second type is there is no change between the frequency or the severity of migraine throughout pregnancy. It is as it is, the same frequency as in the pre-pregnancy. It continues throughout all the three and the postpartum. The third thing is this is the majority of these people. God always protects a lot of things in pregnancy. Multiple sclerosis he protects, migraine he protects. He doesn't want the pregnant woman to suffer. So the majority of the migraine patients belong to this third category, where the migraine attacks, migraine goes into remission for quite a long period. The moment they deliver, that's the time when it starts peaking. So this is the third type of thing in migraine. So the tension type and all the other tension type headache in the cluster, all these things remain quiescent during pregnancy and peak it during the puerperial period. So what are the benefits and harms of a pharmacological and non-pharmacological interventions to treat acute attacks of primary headache in women who are pregnant? See, the safe medication, there's nothing safe. Most of the medications which are tried in pregnancy are the class C recommendations in pregnancy, and most of them are very, very. So whatever is recommended, I've given you. The during the acute attacks, paracetamol is safe. But if you are using an NSAID, please stop it by 30 weeks. Opiates used very sparingly. Triptans are by far is okay, safe. And in breastfeeding, all are essentially safe during the lactational period. Among the antiemetics, the cyclizine, prochlorperazine, ondansetron, domperidone, all these things are fairly safe. Among the migraine prophylactic drugs, amitriptyline and propranolol are safe. Now, there is a lot of newer thrust is happening on magnesium in pregnancy, migraine, especially in pregnancy. Magnesium also has a protective effect on the development of hypertensive disorders in pregnancy. So as a prophylactic drug for migraine, the magnesium is emerging as a role. And the lot of digital devices, there is non-pharmacological devices which have come in migraine. For example, devices like Cephali or devices like Nerivio. Nerivio is a device where you put an arm band in the arm and stimulates the nerves in the arm. But the afferent stimulation goes and modulates the attack. There is the Nerivio is an FDA-approved device which has shown promise in preventing acute headaches. These devices are now they are trying the trials in pregnancy are going on. Even though the most probably these non-pharmacological therapies would emerge as the first line of drugs sooner or later. So these are the few. Then second, the primary 34 weeks developed headache lasts 2 days. Sudden onset of progressing, increasing in severity as associated with visual symptoms. What are the red flags that you see? If you really look at what are all the possibilities of this patient, the patient was 34 weeks headache in the last 2 days, sudden onset, progressively increasing. What are all the possibilities? For example, disorders of coagulation can precipitate an hemorrhage, or disorders of pressure can also be. Second thing, the disorders of coagulation can produce thrombus. The thrombus can be arterial or venous. Venous, as you know, the cortical venous thrombosis, arterial, a stroke in the pregnancy. The coagulation disorders could be ranging in any of the vasculitic disorders which can involve the coagulation, or like antiphospholipid syndrome or SLE, or even the hypercoagulation factor like protein C deficiency, antithrombin deficiency, factor V laden mutation, and the various thrombophilic factors which inherited protein C, protein S, antithrombin 3 factor V laden mutation, homocysteine, hyperhomocystinemia. All these things can cause thrombus, which can be both arterial or venous. Secondly, coming to disorders of pressure. Pressure is idiopathic intracranial hypertension or intracranial hypotension. Both can happen during pregnancy. I think my subsequent speaker, Dr. Guhan, is going to talk to you on orthostatic pressure. A word of caution is spontaneous intracranial hypotension, that is low intracranial pressure, characteristically presents as postural headache. Patient will not be able to sit. They develop throbbing headache, and when they are lying down, when they become better. And the idiopathic intracranial hypertension, as all of you know, mostly this patient comes, especially after the flourishing infertility clinics where the hormones are being pumped, they become obese and they develop prothrombotic states, and not only that, these people also develop the intracranial hypertension secondary to drugs which are used for infertility. The third is disorders of endothelium. This is a big spectrum, which one is the eclampsia, second is posterior reversible encephalopathy syndrome, and third is a reversible cerebral vasoconstriction syndrome. And then disorders of immune regulation. Any infection can happen in pregnancy also, as also autoimmune disorders. And disorders of structure, and there are tumors and complications, especially. There are certain tumors which contain a lot of estrogen receptors, especially the meningioma, which gets a flare-up during the pregnancy. Second thing is the arteriovenous malformations which have been quiescent. They can become flared up because of the hormonal influence. Cavernomas can surface during pregnancy, and the certain tumors which are rich in progesterone receptors, they can also, the ERPR receptors in breast. Similarly, there are the surface receptors expressed in certain brain tumors. They get exacerbated during that period. So, what are all the headache with raised intracranial pressure features? Patient drowsy, pain increases on lying down, increases on coughing or straining, double vision, patient shows papilledema and high BP. So these are all the things which you can strongly suspect when there is a CVT or intracranial or a focal neurological deficit. If you really look at the tumors and other complications may have visual complaints, and infections and autoimmunity may have fever as a most important, and intracranial hypotension is the orthostatic aggravation. I still remember a lady who was a pediatrician from Kerala. She presented to us. The family brought her. She was on antipsychotics. The patient presented to us. What she says that the family said that whenever she goes to the clinic, she develops a headache. She comes back home, lies down in the bed. Whole day she spends in the bed. She is comfortable. The moment we ask her to go to the clinic, she says she comes back in half an hour with throbbing headache. So the entire family felt it is this is his conversion disorder, and then took her to a psychiatrist and prescribed antipsychotic. It was so, because the imaging was normal. Later on, when she came to us, we said that there's a strong component of orthostatic thing. We started investigating. We used the MR special sequences in MR myelopathy. We were able to, she had a LSCS done for, we were able to pick up a dural tear, which produces a CS of leak. And that has caused the headache, and just an autologous blood patch completely relieved a headache. So spontaneous intracranial hypotension because low pressure, the brain sags, and this is called brain sagging. And this brain sagging can present as this such a severe possibility. My colleague would. So what I'm trying to tell you is orthostatic aggravations are an important thing. What are the ominous headache patterns? The headache patterns, if you look at it, this is the pattern which both my predecessors heard. This is a thunderclap which reaches the crescendo, in a minute, and that is the worst headache of their life. This is the one pattern. The next pattern is gradual headache which sustained for minutes to hours, and the last pattern is the pre-pregnancy. There are small spikes, and now in minutes to hours, which can happen in the third pattern. So, how to analyze the visual symptoms, especially in the migraine associated with this? The migraine can be zigzag fortification spectra or small scintillating lines, or the migraine can present as hemianopia, or migraines can associate with even the central scotomas, bilateral transient loss of vision, or it can have an enlarged blind spot with the peripheral constriction of visual fields. So any of these patterns can happen whenever the patient develops migraine pregnancy. It can happen in other non-pregnant also, but these are the visual. Interestingly, the various aura, which are migraine aura, you would have been thinking, what are the visual aura? You would have seen the few of these fortification spectra or scintillating images which they see and all. They are not only that, they can have corona phenomenon. It's like Buddha mela tala mela or odi irukra mari they can have in every image. They can have what is called the doppelganger phenomenon. The doppelganger phenomenon, they feel that they are double. They have double act பண்ற மாதிரி ரெண்டு உருவம் இது நான் இல்ல இது என்னோட போலி இது அந்த மாதிரி ஒரு ஃபீலிங் மைக்ரேன்ல வரலாம். Synesthesias, the one modality of sensation is you feel something else. You feel color. You start feeling color associated with a particular type of taste. And second, out of the body, I experience all these traits. There are almost 73 to 80 traits which can happen as migraine aura. So migraine is aura. Migraine is no more a simple disease. It's a fairly, I think it's a systemic disease with a lot of other manifestations now. A lot of research is going on in this area. And coming to the three important, the specific postpartum things. One is PRESS, I told you. PRESS is a posterior reversible encephalopathy syndrome. 27 weeks primary, 38 weeks headache, persistent, progressive, sudden bilateral, painless visual loss. You can see that this is the MRI. Here you can see a white matter edema. This characteristically spares the calcarine cortex, even though the visual phenomenon is transient. It is essentially, all of you know that there is the cerebral auto-regulation in the blood, in the cerebral vasculature. This dysregulation of this autonomic dysregulation of this autonomic control, that results in this, resulting in severe white matter edema called posterior reversible encephalopathy syndrome. Commonest symptom is headache and encephalopathy and visual disturbances. Visual loss, no perception visions. The headache PRESS is typically described as bilateral, occipital, or holocephalic or pressure-like. Essential treatment is control of blood pressure and other things. Here, the interesting thing is now the PRESS can happen, frontal PRESS. They can get the brainstem PRESS. Now they're describing spinal PRESS. All this edema can happen anywhere in the subcortical regions. It can happen either the anterior or though commonly only posterior. Frontal PRESS are described. The brainstem PRESS are described. The spinal PRESS are described. And controlling the BP and other symptomatic therapy is the mainstay of treatment of this posterior reversible encephalopathy. Is coming back to this RCVS, the 24-year-old primary, 2 episodes of thunderclap headache, focal seizures with residual deficits, stepwise progression. And you do an angiogram, you see beaded appearance. This headache is attributed to reversible cerebral vasoconstriction syndrome. The puerperium begins with 1 week postpartum, described as new onset headaches with thunderclap variety, peaks within 1 minute, lasts for several minutes to hours, and spontaneously resolves within 3 minutes. This entity, very important again, treatment is symptomatic. One important thing to remember is try to avoid steroids. Steroids are not to be used. So be very careful, don't jump into steroids in these cases. Whenever do an angiogram which shows bleed appearance, you bleed. This is another interesting case called Shigans, postpartum Shigans, which can present as otherwise called the pituitary apoplexy, where acute severe headache with sudden loss of vision due to bleeding into the postpartum or postpartum necrosis, which is called the primary, it can cause primary hormonal deficiencies or because of the stimulating hormones deficiency there. So this Sheehan syndrome is another sudden severe headache and with the loss of vision and brain nerve disturbances which can happen in the Sheehan because the pituitary fossa is pretty close to the optic chiasma. So this third two of a normal vaginal delivery develops headache on sitting up 2 days, then develops a seizure. And this is what I told you, a case of spontaneous intracranial hypertension. We should not forget the cerebral venous thrombosis. The headache of CVT typically has a slower onset, although it can be thunderclap in 10%. Other clinical clues of CVT include signs of intracranial pressure, pulsatile tinnitus, and papilledema. You should remember that there are two systems, the dural venous systems. They drain into the deep venous system. And finally, they drain into there is a pressure gradient of they finally drain into the jugular bulb and then come down. There is an interesting thing which they have noted in this cerebral venous thrombosis is predominantly it picks up the commonest venous sinus, which is the transverse and the sigmoid sinus. And sometimes an infection from the ear or paranasal sinuses can also produce an infective thrombosis. As I told you, postpartum eclampsia is another important thing. Usually seen 7 to 10 days of postpartum. Known patient, previously antepartum eclampsia was there. Patient had an albuminuria, hypertension. Patient is being treated with max self regime. Then postpartum develops sudden elevation of BP and sometimes throwing seizures, severe bilateral throbbing headache worsened by exertion, visual disturbances, and can be also associated with post-reversible encephalopathy is called postpartum eclampsia. So max self is the regimen. And cortical venous thrombosis is no acute phase of CVT. You treat them with low molecular weight heparin. These venous infarcts sometimes can be hemorrhagic. So you don't have to be afraid. This is one situation where in spite of a venous hemorrhagic infarct, we use heparin, either conventional or low molecular weight heparin. Following that, the follow-up is nowadays a lot of trials have come where usage of either vitamin K antagonists like warfarin or the newer anticoagulants like apixaban, apixaban, or apixaban. The commonly used one is dabigatran. The trials are pretty robust for a follow-up period for about 3 to 6 months until the sinuses get recanalized. So, cerebral venous thrombosis, postpartum eclampsia, reversible cerebral vascular syndrome, and the posterior reversible cerebral venous thrombosis, and these are the few of the things which happen essentially in the postpartum. And the flare-up of existing diseases like multiple sclerosis, migraine, genital infections, especially herpes. One of the famous actors were genital herpes, which precipitated the herpes encephalitis postpartum, and seen as headaches as an initial presentation. So then comes to the post-dural puncture headache. PDPH is also a potential in the LS when during the LSCS they have done a lumbar puncture. That can also produce a bilateral frontal occipital in the puerperium. So that is worst when the patient is in the upright position, nausea, neck pain. Factors that increase the risk of post-puncture headache are the younger age, female sex, weight, and other things. Adjustable factors are try to avoid larger needle size, use a cutting tip needle, orientation of the needle bevel properly, and difficulty in placing the epidural. So I thank you for your attention. I summarize that during the postpartum, the common causes are cortical venous thrombosis, postpartum eclampsia. reversible posterior cerebral and reversible cerebrovascular constriction syndrome. And apart from that, any of the primary headaches can get can present, or few of the hormone-based tumors, hormone-expressed surface tumors like meningiomas can get exacerbated, and vascular malformations can also get exacerbated during pregnancy. Thank you for your attention.
Thank you, sir. Thank you for, as usual, the wonderful presentation from our Lakshmi, sir. Sir, not much questions in this. There is only one question. Any psychological element in migraine management?
Migraine is strongly associated with depression, as you all know. There is a, the second and third line of management in anti-migraine drugs. Definitely, the antidepressants, SSRIs have a distinct role, and not only that, the kind of the migraine is strongly linked to limbic. So, not only depression, there's also a lot of anxiety it produces. These migraine people, they are always afraid that they may get a headache during one of their important, especially the marriage. The flashes of light. Most of the migraineurs are very scared for a photo. Now the photo sessions are very, very exaggerated. A lot of photo sessions with so much outdoor shooting in the sun. All the triggers, you can call any trigger for the migraine. And especially the girls, they're afraid because of their first exposure to their future fiance in the photo sessions, exposure to sunlight, standing in different postures with flashes of light can precipitate a migraine, and that can be. So psychological counseling has an important role in migraine. Thank you.
Yes, sir. Thank you, sir. Thank you very much, sir. Thank you, sir.
Thank you, Lakshmi, for the wonderful lecture, and especially this.
Thank you. I'm grateful to IMA, grateful to you, because I have never seen such a huge audience. I'm sure.
Listener, and they will find difficulty in managing the pregnancy because the maternity meeting, a lot of questions being asked in whether you should have done an MRI, CT. So people, general practitioners dealing with pregnancies are really afraid of dealing with pregnant ladies, and especially when they have a headache. I think you have made it very clear, an algorithmic approach, and people need not worry much about having a pregnant lady or postpartum lady having a headache. The approach is very clear. Oh, Alan, thank you, Alan.
Thank you so much. Thank you.
And next topic is by Guhan. Guhan, are you online?
Sir, I'm online, sir.
You can share your slides.
Is my voice audible, sir?
Yes, Guhan, sir.
Yes.
As sweet as you, the words.
Thank you so much, sir. Okay.
It's from Trichandur. Now Trichandur has become very famous in the last few months with the headlines with the Murugan, Trichandur Murugan. So, but I remember Guhan, Trichandur Guhan. So both of the name is same. And why I have included Guhan in this team is that we learn a lot from Guhan. All the newer concepts, updates, and we all learn. And me, myself, and Meenakshi Sundaram and Professor Ellen also praise a lot about Guhan. And I'm happy to learn from him today also. Over to Guhan.
Thank you so much for the kind words, sir. If we have a debate, I'll strongly debate these lines that you just spoke about me, sir. Thank you so much for the opportunity. And I also sincerely thank IMA for giving me this opportunity. And most importantly, I thank my teacher, guru, mentor, and everything in my life, Professor Lakshmi Narasimhan, sir, who imparted me the knowledge that's helping me survive in this world. Thank you so much for that, sir. Generally, in neurology forums, if you are given a talk, you should make sure that you don't talk after Balamurugan sir, or you don't talk after SMS sir, or you don't talk after Ellen sir. Here, I am given the job to talk after Balamurugan sir, SMS sir, and Ellen sir together. It is a very big task for me. And that actually gives me more palpitations than the 800 plus participants. So I'll try to do justice to the opportunity that's given to me, sir. So now we are going to look into an approach to an acute headache in the ER. That's topic 4. So the case that I encountered was a 30-year-old female who presented to the ER with acute onset of headache. She had a history of a chronic episodic headache that she had since teenage. So we'll just decode the words here. The episodic nature of the headache here means that she has been having headaches every less than of up to 15 episodes per month, of at least 8 episodes per day, that was impairing her activities of daily living. So we know that right now she has had a significant headache that was present for more than 8 days, but not more than 15 days per month. So this was present since her teenage. That also suggests the chronicity. But if we are to say a patient had a chronic headache, that means that the patient has had 15 or more episodes of headache per month for at least 3 months. So here we have a patient with a chronic headache. That means she has been having episodes of less than 15, but more than 8, that was significantly impairing her. So the first thing that when a lady presents to us in a ER, the first question that we would have is that, is she having a primary headache? If it is a primary headache, why is she in the ER? Or is she having a secondary headache that we need to look out for carefully? Before that, the single most important general and neurological examination in a patient with acute onset headache that my teacher Ellen sir always tells me and scolds me if I don't do that, the general examination is a BP and the neurological examination is a fundus examination. There's one point that you need to take home today: BP and fundus examination. These are the golden pearls, or rather diamond pearls, in a patient who presents with headache in the ER. So as usual, we were looking for the Snoop patterns. Did this patient have a sudden onset? No. Did this patient have any neurological deficit? No. Examination was normal. Fundus was normal. She was an younger age group, so she crosses this lab as well. It was not an acute onset, a thunderclap headache like we have seen before. She had a previous history. And this is the Snoop 4 that we are looking at. She crossed all these boxes and she does not fit into any of these Snoop patterns. Now we have an extended Snoop, that's Snoop 10 actually, with all the other P's of positional headache, papilledema, progressive headache, and atypical presentation, pregnancy, and all these were crossed out. And now she does not actually fit into this Snoop, but she is presented to an acute ER. So is it possible in a primary headache? Yes, it is possible in a primary headache when the headache is so severe that it's going to impair her activities of daily living. And especially so, primary headache patients can have comorbid depression and anxiety that makes them more worried and bring them to the emergency department as well. So here, since we have had a normal examination, this patient does not fit into any of the factors of the Snoop that we had seen earlier. So most probably this patient has a primary headache and does not require an imaging at this point. So we are looking at either a migraine headache or a tension type headache or a cluster headache or other trigeminal autonomic cephalgias. And there are several other primary headaches classified according to the ICHD. So this is the episodic and chronicity that we were talking about. If it is less than 15 days per month, it's episodic headache. If it's more than 15 days per month for 3 months continuously, then it is a chronic headache. So it can be an episodic migraine or an episodic tension type headache or a chronic migraine or a chronic tension type headache. We encounter migraine patients more in the emergency department than the other primary headache patients. And more so in the OPD clinics as well, the migraine patients are more common than the tension type headache patients. Even though tension type headache is much more prevalent in the general population, it does not really impair their daily activities of living. So on exploring the history further in this patient, she had a pulsatile headache, either sides. It can be either left side or right side. More often, she attributed it on the left side. Photophobia was present, phonophobia was present, nausea was there, vomiting was there, and episodes were around 5 per month in her. Now, looking into the ICHD classification, this actually fits into the box of the migraine that we are looking at. But what we often miss is that
this meeting is being recorded.
In the process of actually trying to fit the patient, we might sometimes not be able to fit the patient into the box. Like in this case, the ICHD says that the patient has to have headache and the patient may have not only unilateral, but bilateral as well. It says either 4 to 72 hours. There are migraine patients who can have less than 4 hours and more than 72 hours as well when we label it as a status migrainosus. And the patient can have bilateral can have mild headaches, and it can be worse, that it might not get worse with movement. These things are there, and these classification usually are there for us to guide, but not fit the patient into the box that we have. And since this patient fits in with this classification criteria, this patient fits in with the diagnosis of a migraine. So let's explore more about migraine, what this patient was going through all her life. So like my professor, Lakshmi Narasimhan sir, my teacher, had earlier mentioned, headache is just one icing on the cake. There's much more to it than in migraine. So we have a prodrome, we have an aura, we have a headache, we have a postdrome. If any of your wives at home had a headache, if your wife is actually losing her temperament, it's likely that she might get a migraine 2 days down the line, because prodrome can start up to 48 hours before. And what is it that we are looking in the prodrome are the mood changes. If you are getting more scoldings, then all the more it's like she is getting into the prodrome of the migraine. There can be cognitive changes. There can be increased thirst. Some people crave more for a particular food like chocolate, and this is all a part of this prodrome. And there can be photophobia, phonophobia, osmophobia, and then aura is there. Aura can be a sensory aura, a visual aura, brainstem aura, or there are several other auras that can happen in migraine. It can happen before the headache, during the headache, or after the headache. Usually the description is before the headache. And now we are looking at the so many changes in migraine, like a migraine ice cream, where these patients have an increased interictal sensitivity between the attacks of the headache. They have heightened levels of sensory perception between the headache, and during the episode of the headache, there is a headache, there is an aura that's preceded by a prodrome. So actually, headache is just one icing on the top. There are cognitive changes, there are motor changes, sometimes there are autonomic changes, there are somatosensory, special sensory, and many more aura, like Professor Lakshmi Narasimhan sir had shown earlier. There are more than 100 auras that are being described in migraine. So just summarizing it in a graph, initially the patient has a prodrome, then develops into a headache, and subsequently a postdrome. That if the patient has a migraine aura during the headache, then it is migraine with aura. So when do we classify as per the criteria is that one or more of the following fully reversible aura symptom, and this is also the reason how we differentiate it from other stroke symptoms or other transient neurological symptoms or other neurological symptoms per se, because this is transient and fully reversible. And it has to have these categories. That is, it should last for more than 5 minutes. That is to differentiate it from seizures. 2 or more aura symptoms can occur in succession, or each symptom lasts for 5 to 60 minutes, and at least one aura symptom is unilateral, and at least one aura symptom is positive. These are the caveats. These are the points that we need to take, the golden points that help you differentiate aura from a seizure phenomena. That if it is positive, it can be seizure or a migraine, but when it is lasting for more than 5 minutes, followed by a headache, it's usually a migraine. But if it is a transient sensory phenomena that's happening for few seconds, then it is most likely a seizure if it is not accompanied by a headache, but we'd require other modalities to confirm the same as well. These are the various auras that we can get in migraine. It can be visual, it can be sensory, it can be speech or language. Patient can transiently be dysphasic and dysarthric. There can be motor, which is the hemiplegic we earlier were discussing about, and the brainstem, which includes the brainstem symptoms such as the diplopia, dizziness, vertigo, and even loss of consciousness. And it can be the retinal pathology as well. I mean, the retinal aura as well, where it can be positive or negative sometimes. So most common is visual. That is because migraine primarily affects more the astrocyte, and the high astrocyte, affects more the neuron, and the high neuron astrocyte ratio is located in the visual cortex. So the triggering of the migraine usually happens in the occipital cortex with the spreading of the cortical spreading depression that activates the trigeminal nerves to produce the pain in the migraine. Now coming back to our case, she had visual and sensory aura. Not all episodes of headache had aura. There were some episodes, in fact, majority of the episodes did not have an aura. Now, if you were to imagine how a patient would have a visual aura, here is one description sketched by a patient with migraine. And this is how a fortification spectra looks like. And it is gradually expanding and it goes to the periphery and leaves out of the field. And here is one such video, which is showing you how the aura actually evolves over minutes in a patient. This is actually an accelerated video. This actually evolves over minutes, and the margins you see is a silvery line. Okay, this silvery line is very important because when it is colorful, that is when we consider an aura. Is it an occipital epilepsy? Because this is one of the features that we differentiate. Only an aura, only a visual phenomena happening in these patients. If it is black and white, it is usually a migraine related aura. If it is colorful, it is usually an occipital seizure. This is how a sensory phenomena progresses in a patient with migraine, but it usually happens over few minutes. If it is a seizure, it is going to happen in less than 5 minutes, say 1 to 3 minutes. If it's more than 5 minutes, it's usually a migraine with sensory aura. And if it is a sensory seizure, further, it will be stereotyped. For example, if it starts from the forefinger, every time it is going to start from the same forefinger and it is going to have a march proximally towards the shoulder or whatever pattern it is going to maintain. And this slide, I stole it from Lakshmi Narasimhan sir. Since you heard it from the master himself, I'm going to skip this slide. And since our patient had an aura, she comes and asks us or rather, what are the implications that I have because of my aura? So what are the things? One, if the patient has a aura, that is an increased risk of perioperative stroke than those without aura. These migraine with aura patients also tends to have more comorbid depression, suicidality, bipolar disorder, panic disorder, and anxiety. And migraine with brainstem aura and hemiplegic aura, they usually have vasoconstriction, severe vasoconstriction, and they poorly respond to triptans, and triptans can theoretically increase the risk of stroke in them. The other is that migraine with aura, there is increased prevalence of patent foramen ovale in these patients. And this is another debatable topic. Do I close the PFO in these patients? But not for today. We are not going to take this topic for today. But the presence of PFO or presence of atrial septal defect can increase the prevalence of migraine. This is because of the paradoxical emboli that goes through this atrial defect and triggers a cortical spreading depression in the occipital lobe and thereby causes migraine. There are patients whose migraine were aborted following closure of the PFO. So this also suggests that the migraine patients, the increased prevalence of migraine in patients with PFO. Now coming to the post-drome is the period between the resolution of the headache and the patient completely returns back to normal. Still, these patients are not normal at this time. They do have their mood changes, they have their tiredness, increased urination, fluid retention, constipation, anorexia, so non-specific symptoms that they do not return to their activities of daily living. So let's focus on some of the variants of migraine that we see in these patients. One is the hemiplegic migraine, basilar migraine. So a hemiplegic migraine is going to present with a classical headache and a hemiplegia. So how do we differentiate this from a patient who has a headache with a stroke? Is that the hemiplegic migraine patients will also have other involvements as well, such as ataxia, and they usually have confusion as well and can also have a depressed sensorium, not just limited to one neuroaxis, but multiple neuroaxial involvement than a simple stroke. And in fact, a hemiplegic migraine, the symptomatology might not be the headache primarily. They focus more on the hemiplegia. And when asked about the headache and the other symptoms, they do tell about it. Hence, when we explore more about these symptoms, we will get to know more about the hemiplegic migraine and probably helps to differentiate it from stroke. The other is a basilar migraine, which is now recoined, the term is recoined as migraine with brainstem aura, where the patient tends to have diplopia, vertigo, and depressed level of sensorium. And then this patient might have had a headache, that would help us label this patient has been having recurrent episodes. The others are not so common. Even the first two are not so common. These are rarer than the first two. Childhood periodic syndromes, where the child presents with abdominal pain cyclically, retinal migraine, which can be positive visual phenomena. Now in retinal migraine, we are going to have negative visual phenomena. The controversial term of ophthalmoplegic migraine, where migraine is the headaches are associated with recurrent ophthalmoplegic cranial nerve palsies involving the third nerve, and we are unable to find the other cause, such as the granulomatous cause of Tolosa-Hunt syndrome, because that's the first thing that comes to our mind. Is there any other cause that is causing headache plus third nerve palsy? If we are unable to find any other cause, then recurrent painful ophthalmoplegic neuralgia, that's the ophthalmoplegic migraine, is on the cards. Complicated migraine is when the aura lasts longer than the primary headache itself. Then we call it as a complicated migraine, but that also is out of vogue right now. We don't commonly use the complicated migraine. So these are the things that we're discussing so far. Now coming to the mimics. When headache isn't actually what it seems, this patient presents with migraine. What else am I to look out for to see if this is not actually migraine? I am looking at secondary causes, but it's so similar and deceiving me into thinking it is a migraine. So the first thing is that majority of the time it's migraine, but there are times you are actually looking into something else. So classical pattern, whatever we are discussing in this, is a same headache, photophobia, phonophobia, pulsatile, throbbing headache. And these are the times there are patients who will have a migraine phenotype and will tell you that I am tearing on one side and there is a nasal stuffiness on the same side. So now, do I classify this as a cluster headache or do I classify this as a migraine? Because a classification system does not help us identify is it a cluster or a migraine. Then comes the classification system, which tells us to label it as a cluster migraine overlap and treat it with a preventive treatment for the predominant phenotype. So that's how this cluster migraine concept has evolved. As I have mentioned earlier, BP, blood pressure and fundus is the golden pearl in a patient who presents to the ER with headache. Then the carotid artery dissection. It's like SMS sir was discussing about it. Headache, if there is a Horner syndrome, search for carotid artery dissection. It rule out carotid artery dissection with all the possible means. Migraine phenotype with a Horner syndrome, carotid artery dissection. Now, if this migraine, normally a migraine resolves on getting up. The patient is going to get up with a headache every time. Early morning migraine gets up with the patient assumes upright position with a headache. Then we also have to rule out two things. One is an obstructive sleep apnea. It's obstructive sleep apnea can cause a headache by itself. If the patient is also a migrainer, then it can trigger the migraine episode when the patient gets up. The other thing is raised ICP headaches that includes a mass lesion and cerebral venous thrombosis. Of course, these patients are also going to have transient visual obscurations. That is, when they bend forward, the eye vision is going to diminish transiently. Sixth nerve palsy can be there and papilledema can be there. If this migraine pulsatile headache patient is present for only a week with no previous history and a fever, then I'm looking at meningitis. If the migraine for the first time happens in an elderly, then I am double, triple, and in fact cautious for 100 times to label it as a migraine, because migraine usually does not have its onset in the old age. More than 60 years, specifically with scalp tenderness and jaw claudication, I'm going to look at if it is a giant cell arthritis, because timely initiation of steroids in giant cell arthritis can save the vision of the patient. The next thing is the RCVS, which we have gone through sufficiently. Most important point, not all that throbs is migraine. Recognize mimics to avoid disasters. Primary headache, there can be a cluster overlap. Secondary headache, look for the mimics. Now let's go to the borderlands. Is it migraine or is it something else? We do not have an exact answer. Those are the cases we try to label it like those patients who have a migraine borderland. So if a patient with a migraine develops stroke, what are the things that I'm going to look at? On the first place, migraine with aura has an increased risk of stroke. The second thing is that these patients can have an atrial septal defect or a patent foramen ovale and can have a paradoxical emboli that results in stroke. Migraine in severe episodes with vasospasms can theoretically cause a stroke. And those patients with hemiplegia, that is with headache, this could be a familial hemiplegic migraine if the patient had a family history, or a sporadic hemiplegic migraine if the patient did not have a family history. The most common type has its problem in the calcium channel defect. If the patient has a migraine in the 20s, stroke in the 40s, and dementia in the 60s, then probably we are looking at CADASIL, which is cerebral autosomal dominant arteriopathy with subcortical ischemia and leukoencephalopathy. So this is like imaging in CADASIL, which is a genetic cause for stroke. These patients would have had migraine in the teenagers, and usually the imaging reveals the white matter changes. But what's more pressing, how do we find out that this is CADASIL from the imaging, is that if there is anterior temporal involvement or external capsule involvement, then I am looking probably at CADASIL. The next thing, if the patient has had a migraine, if the patient has had a stroke-like episode, if the patient has had a sensory neural hearing loss, then could this be a mitochondrial disorder? Mitochondrial disorder, the whole spectrum that can have migraine, headache, stroke-like episode. The classical example of a mitochondrial disorder with migraine stroke-like episode is MELAS, which is mitochondrial encephalopathy with lactic acidosis and stroke-like symptoms. And here the imaging feature is little going to be different, where it's not going to be confined to the vascular territories. It's going to affect the posterior cortical regions more predominantly than the anterior cortical regions. Migralepsy, a controversial term, but when we label it as a migralepsy, it's like the epileptic seizure has happened at a maximum of an hour after a migraine aura. TGA's transient global amnesia can happen in patients with migraine. That's one thing to note down and keep in our mind. Now, coming to the chameleons, the possible presentations of migraine posing as other condition. This is the most important thing we need to, because migraine as an aura can have a negative symptom mimicking a stroke or a TIA, or can have a positive symptom and can mimic an epilepsy. It can do either ways. Only thing is that the patient would have had history of migraine. That makes a job easier. But if that's not the case, that's when we are put to test. Especially in visual aura, if it's black and white, as we have seen earlier, it's more of a migraine. If it is more complex, colored, and it lasts for less than 3 minutes, then it is usually an occipital epilepsy. There's other migraine limb pain syndrome that I wanted to discuss, which is very commonly we encounter migraine patients complaining of pain in the either a left upper limb or a right upper limb. These are migraine limb pain syndrome. This usually happens because of the migraine affecting the brain, and not per se because of the cervical radical or a carpal tunnel syndrome. And how do we know about it? We test for the provocation maneuvers. We look for the Kemp's test. We look for the Sperling sign. And if these two are negative, it's unlikely to be a cervical radiculopathy. We look for the Fallon sign. We look for the Tinel sign. If it is absent, it's unlikely to be a carpal tunnel syndrome. And we usually give preventive treatment to the migraine. And if that improves, then we attribute it as a migraine limb pain syndrome. And coming to the treatment part, so there are various, we can use NSAIDs, triptans, ergots, or combination in the treatment. And preventive treatment, this is from an article by Lakshmi Narasimhan sir. And coming to the acute treatment, if a patient presents to the emergency department, let me come to this flow chart and then come back to the preventive treatment again. When a patient presents to the first for the flow chart in the emergency department, the options that we have are subcutaneous sumatriptan, prochlorperazine, and metoclopramide, chlorpromazine. These are the initial options if it doesn't help. And if there are no vascular risk factors, then ergots can be considered. And ketorolac IM is a very good choice in an emergency department. And to prevent the recurrence of the headache over the next few days, dexamethasone is very helpful. So what we normally do, we hydrate the patient adequately. That's the most important thing, because migraine patients, dehydration triggers migraine, and migraine patients due to nausea and vomiting would not have had their dose of fluids for the day. hydrate them adequately, and give an injection ketorolac 60 mg if it is very severe. And if the patient is elderly, then we give 30 mg. And to prevent recurrence, dexamethasone. These are the options that we can do. If still pain is not recovering, then we have other options as well. And the preventive treatment depends on the indication. Like if these patients have 3 or more headaches per month that is causing functional impairment and are not responding to acute treatment, 6 to 8 headache per month, even if the acute medicines are effective. The patient has contraindication to acute migraine treatment, or even if a single attack that is very bothersome to the patient, like the migraine with brainstem aura, the hemiplegic migraine, or if the patient feels that migraine is impairing my activities of daily living, and if the patient has a risk for medication overuse headache, then we use preventive treatment. This includes lifestyle modification, avoid triggers and risk factors, medications and nutraceuticals. With regards to nutraceuticals, American Academy of Neurology recommends magnesium, riboflavin, and coenzyme Q10 for the prevention of migraine. Neurostimulation and modulatory therapies can help. Behavioral therapies can help. This is the whole list. We have antihypertensives for prevention, antidepressants for prevention, anti-epileptic drugs, and the easy to choose. If the patient has migraine and hypertension, young age is beta blocker, old age is calcium channel blocker. If the patient has had a Raynaud's phenomena as well due to the vasospasm, then we consider calcium channel blocker. The patient has had a depression and a mood disorder with migraine, then antidepressants. If the patient has had insomnia, antidepressants. If the patient has a migraine and an epilepsy, then we consider anti-epileptic drugs. If the patient has migraine with aura, then we use anti-epileptic drugs, so, topiramate or sodium valproate. If the patient has migraine with medication overuse headache, topiramate is a good choice to consider, though there are other options available as well. And obesity, we consider topiramate because it can induce weight loss. Just touching up on the trigeminal autonomic cephalgias, the cluster headache, this is the pathophysiology. There is activation of the hypothalamus, posterior hypothalamus, that produces the circadian rhythm. Cluster headache happens at the same time every day. Yesterday 8 a.m., today 8 a.m., tomorrow 8 a.m., usually 80% of the time. And then it activates the trigeminal vascular system, causing the pain. Third, it activates the superior salivatory nucleus, causing the lacrimation. So if I were to target the hypothalamus, which caused the onset, the target for that is verapamil and lithium for the preventive treatment. And for improving the pain, trigeminal nucleus, triptans. For the superior salivatory nucleus, the target system is oxygen. So just summarizing for tax column wise, if the trigeminal autonomic cephalgia, stabbing headache with autonomic symptoms, if it is seconds, it's Sanctsuna. If it is for 2 to 30 minutes, it is paroxysmal hemicrania. If it is for 15 to 180 minutes, I'm looking at a cluster headache. If it is for more than it continues beyond for several days with superimposed episodes of attack, then I'm looking at hemicrania continua. Oxygen is very useful in cluster headache, not effective in other attacks. Indomethacin is 100% responsive in paroxysmal hemicrania and hemicrania continua. In fact, it can be used to diagnose these conditions as well. So these are the just one take-home message at this point. If a patient has a cluster headache, imaging will be required to rule out the secondary causes of pituitary tumors, meningiomas, glioblastomas, and vascular causes, that is vertebral or carotid artery dissection. And these are the treatment options: high flow oxygen in the acute phase, and triptans, either an oral or a subcutaneous or a nasal triptan. And in the transitional phase, we give them steroids. And then to prevent, verapamil or topiramate or lithium or melatonin is useful. Thank you very much for the opportunity, sir.
Thank you.
Nice presentation, Guru.
Thank you very much, sir.
There are a few questions in the chat box. One is, what is the mechanism behind the trigger factors inducing migraine? How the trigger factors induce migraine?
So
Another one is, females when exposed to sunlight, they develop migraine. Why and how to treat?
All the trigger factors, each patient will have their own individualized trigger factors. There are migraine patients who are exposed to sunlight and get migraine. There are migraine patients who can stay in the sunlight for a very long period of time. Whatever is the trigger for that particular patient, it is usually a factor that is able to trigger the cortical spreading depression from the occipital cortex. And this cortical spreading depression, I did not have time to discuss about that. It starts from behind, it goes to the front, and then it activates the trigeminal vascular system. Once it activates the trigeminal vascular system, there is this pain. So any trigger factor that is able to trigger the cortical spreading depression in these patients, because these patients are, even if we do a measuring of the amplitude in the occipital cortex in a migraine patient, when they do not have an attack, the amplitude will be higher. The visually evoked potential amplitude will be higher than a normal patient. And therefore, there are humpty number of triggers. The sunlight, the way that it causes trigger is through dehydration. Dehydration is one of the trigger for migraine patients. And the best way is to prevent a migraine attack during a sunlight is to keep them hydrated. And if it still happens, then that warrants a preventive treatment if it meets the criteria.
Yes, thank you. And one important point you slightly mentioned about that. Is that the trigger or is it the program phase? So you said probably didn't want to confuse the people. So during the program phase, most of the people feel what they have the symptoms as a trigger. So there's a new concept coming. So is it that rather than the spread, it is the hypothalamic activation starts first, and that causes the symptoms of taking the chocolate, overeating, or sleep deprivations. These are the part of the program. So some of the programs we think this is a trigger that causes the migraine. I really appreciate when you are telling that the program itself may be the manifestation or maybe the misidentification of the trigger. That also happens frequently.
Yes,
Thank
sir.
you.
I learned more.
One more question is,
I learned
Yes,
more of the
sir.
migraine from my wife who has migraine. She used to consume a lot of chocolates. When she consumes chocolates, I'm not gonna get more scoldings the next 2 days. So I went up and looked up the literature. I couldn't find a single literature that says chocolate triggers migraine, or rather, the craving increases during the prodrome, and that's when they start to get the headache in the subsequent day.
Correct. There's a program that causes that craving. So that may be the reason that also. Okay, so you are able to have a balanced life for learning migraine, I think.
Bala, one more question. That is, any exercise to prevent migraine when it gets stimulated by crossing that zebra crossing lines, or seeing vertically or horizontally arranged lines or anything. I think someone's own experience this is. He's asked like this.
Visually trigger the visual, because this stimulates the vestibular nuclei. See, I make it very simple. Any 5 sense, when it gets, these are all, migraine is a hyper-excitable state of all your 5 sense. Your vision, your smell, your taste, and your hearing. And we always said the hearing alone, that one more sense in the hearing is the vestibular. So the travel associated migraine may be the sunlight or the visual vestibular stimulus. So the zebra lines are people traveling and then looking at the cell phone and then texting during travel. That produces migraine. I say that most often it is the vestibular stimulation that causes the link with the migraine. So wonderful question. So a lot of people personally say that when they close their eyes when they travel, they don't have any problem. When they text while they are traveling, they have more problem. So that is a vestibular stimulation, or vestibular is hypersensitivity for these people, and then they have the migraine.
One more question is treatment of childhood migraine.
Guruvai, Varvai, Arloi, Gurne. Guru.
Sir?
Guruvai,
treatment of childhood migraine.
Childhood migraine. They ask about childhood migraine treatment.
The treatment of childhood migraine is that usually we start with lifestyle modification. If that is not able to help the patient, then we can prescribe the patient the nutraceutical medicines which have been approved by the American Academy of Neurology, which is either riboflavin and magnesium and coenzyme Q10. And if still that doesn't help, then we can start, after informed decision making with the patient, a beta blocker in the lower doses adjusted to the weight.
Okay, thank you. Thank you. Shall we go to the next session? I'll share my slide.
Last session by Dr. Rangarajan, the Hosur neurologist, and I know him for the past 25 years from his post-graduation, because we share some of our cases for the last 20 years. And astute neurologist, his case files teaches a lot about the case summary, and I really enjoy looking at the case files also. And now over to Dr. Rangaraj, and on the topic on
my slides are
and
visible?
we said that the slope, we said that the onset is a one thing, onset to peak as a plus the thunderclap that I spoke, and only onset at the age of 40. So that was the specific topic given to Dr. Rangaraj.
Thank you, Bala, for giving the topic to me. This is
yes,
slide
visible and audible.
Visible audible,
audible, visible and audible, both. You can change the slide.
Yes, okay.
Yes.
This is a 70-year-old male patient, came to my OPD with a history of headache, bilateral associated with transient visual obscurations. So first question is it an emergency, whether we have to treat him immediately? Not like this, but still it is an emergency to prevent the further complications, because there is a visual disturbance. And these are the red flags in headache. As it was told in most of the speeches, in this patient, it is a sudden headache, onset after the age of 55. There are abnormal neurological signs like the visual disturbance, and we have to find out if there is any local tenderness while we are testing it. So in the history, it is only headache and visual disturbance. There is no mention about the past history. So if a 70-year-old male patient present with a past history of headache, could it be a migraine? Unlikely in this age. Could it be tension type? This is also unlikely. Could it be cluster? Possible. Or any other secondary headaches. But there is no history of fever, no respiratory infection, no trauma. And could it be a cortical venous thrombosis with seizure? There is no seizure. And could it be a press? Because press with occipital disturbance, occipital lobe disturbance, some visual disturbance can happen, but there is nothing. And could it be a temporal arteritis? Because that is the commonest in this old age with headache and visual disturbance. So, as usual, we did a general examination. There is no fever. If there is a fever, it could be an infective or it could be also an arteritis. The pulse rate, there is a little bit of tachycardia. BP is normal. Duan is telling most of the headache cases, we have to just examine the pulse, BP, and fundus everything. And the BP will tell you about any associated hypertension. And as Bala told, systolic BP, diastolic BP above 120 or more than that, the patient may have a headache. And other systems, any joint pain or rash. But in this patient, there is nothing except headache and visual disturbance and mild tachycardia. And higher function is normal. There is a disturbance in vision, visual loss and headache. And above the age of 55, the commonest causes the temporal arteritis. The other rare causes are could it be a pituitary lesion with hemorrhage into the lesion? Because a pituitary lesion as such will give rise to some hemianopias or some things, but sudden hemorrhage into the lesion can present with a visual disturbance. But will there be headache? Unlikely. The other things are press, cerebrovascular disease, CVT, all these are visual disturbance can happen, but it will be hemianopias or other field defects, not a total visual disturbances. Any other cranial nerve disturbances? In this patient, there is no motor sensory deficit and no neck stiffness. If there is a neck stiffness, it could be a meningitis, but nothing is there in this patient. So then we did the local examination, tender, palpable, superficial temporal artery. So it is a case of temporal arteritis. So temporal arteritis is an inflammatory disorder of arteries commonly involve the external carotids. Above the age of 50, average age of onset is around 70, and it involves women around 65% of cases. Headache is unilateral, gradual over few hours, and then it peaks. Throbbing or dull boring, and most of the patients will tell, sir, எனக்கு இங்க இருந்தா பெயின் அப்படியே இங்க இடம் மட்டும் இருக்கு அப்படின்னு. So நமக்கு அடுத்த டிஃபரன்ஷியல் டயக்னோசிஸ் வந்து it could be a trigeminal neuralgia, could it be அப்படின்னு, but it doesn't present with the visual disturbance, and it is worse at night and increase with exposure to cold. And some patients present with the jaw claudication in a long term, like 1 or 2 weeks, that could be malaise, muscle aches, and polymyalgia rheumatica, and then sometimes very rare weight loss. So when to suspect temporal arteritis? Age above 50, presenting with new onset headaches, abrupt onset of visual disturbances, especially transient monocular visual loss, associated jaw claudication, systemic symptoms like unexplained fever, anemia, weight loss, asthenia, anorexia or fatigue, and local tenderness. So the next test is to do investigations. We did as imaging, the CT is normal. The next step is ESR and CRP and platelets. In this patient, the ESR is elevated, platelet is elevated, CRP is mild elevated. But normal ESR doesn't exclude, but normal platelets, you have to just suspect your diagnosis. Is it a temporal arteritis? And final diagnosis is biopsy, but it is very, very unusual. Most of the cases, it is a clinical diagnosis. Headache, visual disturbance, pain, elevated ESR, elevated CRP, elevated platelets, and local tenderness, suspect temporal arteritis. And the complication is ischemic optic neuropathy, and around 50% of patients, if untreated, will develop blindness. It is one of the major cause of rapidly developing bilateral blindness in patients above 60 years. And treatment of our temporal arteritis is prednisolone 80 milligram daily for 4 to 6 weeks. Because most of our physicians give Viceron 10 mg, 20 mg, and this patient, most of the time, they don't respond, and they continue to have a pain, and they develop complications. So when you use a steroid, use it as a steroid, and prednisolone 80 milligram daily for 8 to 6 weeks, along with other antacids and analgesics. And even long-term medication is needed, we can use, or a steroid sparing effect, we can use a methotrexate. And any other differential diagnosis? Could it be any primary headaches? Because as we discussed in the initial itself, unlikely to be a migraine or any tension or anything. Could it be a cervicogenic headache? No, there is a visual disturbance is there. The same pain can present with trigeminal neuralgia, but there will be no visual disturbance. All the other causes are for facial pain, facial or temporal pain, the dental infection, glaucoma, cardiac hepalgia, and all the other things. And The closest differential diagnosis is trigeminal autonomic cephalalgias like cluster headache, paroxysmal hemicrania, SUNCT, and SUNA. Just now, Guhan told about this cluster headache, deep excruciating pain, non-fluctuating, explosive, daily bouts. It happens in clusters, continuous 1 to 2 for 8 to 2 weeks in a year, common with men. There will be ipsilateral conjunctival injection, oral fullness, rhinorrhea, photophobia, and phonophobia. And most of us know the treatment is, because it is a common MCQ question, 100% oxygen at 10 to 12 liters per minute and smartriptan. And the prevention is prednisolone, verapamil, and lithium. Just now, I think Guhan also discussed this. And they have tried neuromodulation therapy also. The next is paroxysmal hemicrania, unilateral severe long-lasting episodes with the lacrimation nasal congestion. Male-female ratio is 1:1. We can think about other secondary causes like cellular tertiary lesions or others. Treatment is with indomethacin. SUNCT, severe unilateral orbital or temporal pain, at least 20 attacks per day with conjunctival ingestion and lacrimation. And there will be cutaneous trigger of attacks and lack of refractory period to trigger in between the attacks. Treatment is with IV lidocaine and long-term lamotrigine, gabapentin, carbamazepine, and then topiramate. This is another differential diagnosis, that is hemicrania continuum, but all these present with only pain and autonomic features. There will be no visual disturbance. So in our case, it is temporal arteritis because the age above 50, abrupt onset of visual disturbance, mild systemic symptoms, local tenderness, elevated ESR, and treatment is, we started him on steroids. Thank you. Thank you, Bob. Hello. Bala, any questions in this?
My screen visible, sir?
Yes, Peri.
Okay, can I start, sir?
Your screen is visible.
Yeah.
Make it as a
Can I start?
slideshow. It is seen. Yeah.
Okay.
Rangarajan, sir.
No, close.
Can we start?
Yes. Start.
Yeah.
Okay, it's full screen, no?
No, Perigarapan, it is in. Now it is full screen. Yeah, that's right. Okay.
Okay, right. Just at the outset, I would like to thank Anand and IMA team for giving this opportunity. This is mainly since many neurologists over here spoke about headache, trigeminal neuralgia, other thing. Being a ready, I'll tell you when and what imaging modality you need to use in a patient with an headache. Whenever somebody has an headache, when they present to a doctor, they ask whether it could be managed with a conservative like a tablets alone or when you need to image. From a medical graduate perspective, radiology, we have multiple investigations. Initially, it started with X-ray, then CT and MRI. Now, the present era, whenever X-ray is totally outdated, particularly in the context of neurology. So X-ray is not at all done in a case of neurology. It is only either CT or MRI. So whenever somebody presents with an headache, what are the imaging you need to do it? When the patient has, there are different clinical scenarios when they could have an headache. When their headache could be associated with a vomiting, with visual loss, or there could be like a migraine, like a constant headache, which could change in clinical scenario. It could be associated with the seizures, or sometimes it could present with the weakness of one side of the body, or secondary to trauma, they could have an headache. These are the common scenarios which we encounter. As I said, radiology, there are multiple modalities, CT and MRI. What is the difference between a CT and MR is a CT is got a radiation hazard, MRI is without radiation. The advantage with the CT, which could finish in a shorter duration of time, the entire CT scan could finish in just 20 or 30 seconds. In an acute setting, when you want to decide about what next treatment patient require, CT is indicated. Next, cost also compared to MRI, CT would be cheaper. So earlier decision making, when the patient is in a sick state, or you want an acute decision making, or you want to rule out life-threatening conditions, CT is done. So next coming, I told what are the indications for CT. One is a severe headache of their lifetime associated with the vomiting, or headache presenting with a sudden neurological deficit, or headache associated with the seizures could be due to tumor or sometimes occult bleed in the brain, or patient's conscious level is low means CT, because that patient could not be subjected for an MR. MRI is magnetic resonance imaging. Compared to CT, there is no radiation hazard in an MRI. So MRI compared to CT will take more time, around 20 to 30 minutes for completing an MRI brain. CT has got only 2 studies. One is a plain CT brain, other is a contrast. Whereas MRI has got multiple sequences. Down the talk, I'll show what are the images, how you need to be aware of these images. So when you have to do an MRI, MRI is magnetic resonance imaging. Routinely not, first presentation of headache is not required to do an imaging with a MRI or anything. If the patient is imaging, headache is atypical or associated with a neurological deficit or a seizure disorder, then you can ask for an MRI. MRI is particularly useful for a stroke, particularly affecting the posterior circulation. When CT has identified some abnormality, to further characterize, MRI might be useful. In brain, as per undergraduate teaching, there are 2 things. One is the outer will be the gray matter, inner white matter. These differentiation compared to CT will be better appreciated in MRI. To identify these abnormalities, MRI is better. Patients' headache with a seizure disorder compared to CT, MRI will show like mesial temporal sclerosis, particularly cranial nerve imaging like trigeminal neuralgia. The speaker before spoke about trigeminal neuralgia, the neurovascular conflict, everything could be picked up with an MRI, which will not be possible in a case of a CT scan. Then malignant or benign lesions could be picked up on MRI. The disadvantage with MRI, it takes around 20 to 30 minutes. In an acute setting, it will not finish. So the patients with a chronic headache with atypical presentation, you can ask for an MR. In a pediatric cases, you can ask for an MRI because it is not having any radiation hazard. CT has got a radiation hazard. So in this talk, since it's for mainly for MBBS graduates or GPs who are practicing, if you identify the basic abnormality, that is more than enough. As I said, CT is mainly useful for acute setting. If you identify the hemorrhages, fractures, in that cases, if you refer, that will be useful. The important thing is the epidural, extradural hemorrhage. If you see like an idli, like a convex shape, like a lenticular shape, this is an extradural hemorrhage. CT, how to differentiate? This is a brain parenchyma, which will be gray in color. This bright area is a hemorrhage. Bone also will be bright. There are 2-3 structures which are bright in a CT scan. One is bone, skull vault bone will be bright. Next, hemorrhage, then calcification. So normally calcification will not be there in the brain parenchyma, only in the choroid plexus it could be there. Rest of there should be no bleed in the brain. This is a lenticular shaped extradural hemorrhage. Usually the patient could have had a trivial fall or a fall. After that, patient would be normal. After 2 or 3 hours or a day, the patient would complain with an headache with an altered sensorium. In that cases, if you do CT, which will pick up, these patients need to be referred for earlier surgical intervention. That is extradural hemorrhage outside the dura. Brain is covered by a meningeal covering. This hemorrhage is outside the dura. This is another hemorrhage. As I said, this is anything which is bright on CT is bleed or calcification. This is a subdural hemorrhage. This is beneath the dura, subdural hemorrhage with a mass effect. So this has two layers, acute and chronic subdural hemorrhage. These type of hemorrhages will be better picked up in a CT in a shorter duration of time. Another clinical entity which I told, headache of life-threatening, thirst, thunder, headache, they will tell. I have not had an headache like this. If they tell it is a subarachnoid hemorrhage, in that case, only what is required is a plain CT scan. This is a CT brain image. This is a outside will be the gray matter, inside will be the white matter. In a CT scan, white matter will be slightly black compared to the gray matter. The CSF will be black in color. This is a ventricle which contains a cerebrospinal fluid, which is black in color. The sulcal spaces, this is a Sylvian fissure, which contains a cerebrospinal fluid, which is black in color. Compared to this is right side, this is left side. Here you could see within this Sylvian fissure, there are bright areas. Anything on bright on a CT scan is a hemorrhage or a calcification. This is a subarachnoid hemorrhage. This patient will have, they will not have any history of fall or anything, sudden severe headache. This is a subarachnoid hemorrhage. Commonest non-traumatic cause is an aneurysm. Then you have to subject the patient for a CT angiogram. Next is a intraventricular hemorrhage. In the previous slide, I showed how to identify the ventricle which contains the cerebrospinal fluid, which is black in color. Here, if you see, this is white in color. This is not calcification. Calcification will be only very small. This is the entire ventricle is filled with the blood. This is also intraventricular hemorrhage. This patient could also have a severe headache. These are the red flags in a patient with an headache. Severe headache or could be associated with a vomiting or a seizure disorder. This is a clinical scenario is a 26-year-old female with an headache with a seizure disorder. You could see this is a CT brain image at the brainstem level. You could see this is a midbrain level. This is a cistern, ambient cistern and a quadrigeminal cistern which contains cerebrospinal fluid. You see, compared to the right side, left side, there are some bright areas in the temporal lobe. This also a reproductive age group female who recently delivered. This bright area is a hemorrhage. This is not calcification. Adjacent, if you see, these are the brain as one pure blood. This is an artery. Then it drains through the vein. This is a sinus in the brain. Transverse sinus is thrombosed associated with a venous hemorrhagic infarct in the temporal lobe. This patient could also have a severe headache, particularly female in the reproductive age group or females who are on oral anticoagulant. If they have a severe headache or during pregnancy, if they have severe headache, important suspicion is a dural sinus or cortical vein thrombosis with an hemorrhagic infarct. This is a hemorrhage in the temporal lobe. This patient can present with an headache or with a seizure disorder. So in a childhood also, it can happen due to dehydration. In a pediatric age group who has recurrent diarrhea, patient present with an headache and a seizure disorder, you need to image to rule out dural sinus thrombosis and hemorrhage. This is a elderly 51-year-old male with a severe headache and weakness of one side of the body. As I said, CT is very good in picking up hemorrhage. This is a brain parenchyma. This is a normal right side. This is left side. You see within the thalamus, there is a bright area. This bright area is a hemorrhage. So when somebody complains severe, that like now we have pain score for everything, like a 0 to 10. If the pain score is more, normally everybody will have a mild headache like a 0 to 3 or 4. If the pain score increases more than 6 or 7, like in the current era of medicine, if we miss these type of hemorrhages, it's a medical negligence. So we can do imaging and rule out hemorrhage. Like a severe headache, we need to hemorrhage. We need to image and rule out hemorrhage. Next, somebody like a trivial elderly patients who had a fall, if they have hemorrhage, if they have a headache, then we need to hemorrhage to rule out subdural hemorrhage, or sometimes fractures will be better picked up on a CT. In that cases, we should not do an MR. These fractures will be better picked up with a CT scan. These type of this, if you see the skull vault, the bone will be smooth. Apart from the fissures, you could see the subtle irregularity. These are the fissure fractures, which doesn't require any surgical intervention. Only depressed fractures requires intervention. Like a fissure fractures needs only a follow-up. Bone abnormalities, you need to do a CT scan. Next, another neurological scenario is a ischemia, stroke. Stroke, when somebody has weakness, sudden weakness of one side of the body, if you are in a small setup or hospital where you can thrombolize or anything, you need to ask the history at what time the weakness started. If it is less than 4.5 hours, you could do a CT scan. CT scan is done, as I showed in the previous slides. You have to rule out hemorrhage. You can ask the radiologist over there. If there is no hemorrhage, the patient can be subjected for thrombolysis. If it is not, if you are not very sure about the diagnosis, then you can do an MR to identify the infarct. If the patient is in a window period, you can thrombolyze or refer to a IR center. These are the early signs of the patients with a stroke. CT itself could pick up early stroke. Patients who has weakness with acute onset of not able to move one side of the body. This patient had a right upper and lower limb, is not able to move. He came to hospital around 4 hours. When you do CT plane will be normal. If you see in the sulcal space, there's a bright area. This is called as a hyperdense middle cerebral artery. This is called as a dense MCA sign. This indicates a acute, hyperacute infarct involving the middle cerebral artery. If the patient comes within 4.5 hours, even in this case, you can just give an IV thrombolytic agent like a tenecteplase or Actylize, or you can refer to IS center for further management. CT is not done to diagnose, to rule out hemorrhage. If you could identify these abnormalities, you can refer to a IS center. Next, coming to MRI. MRI is a magnetic resonance imaging. Whenever you suspect, your clinical suspicion is like a tumor or a seizure disorder, or if your stroke like a bizarre clinical feature, then you can ask for an MRI. MRI takes around 20 to 30 minutes. It is not having any radiation hazard. There are multiple sequences in an MRI. It will done in multiple planes. CT predominantly done in the axial plane. You could reconstruct in coronal and sagittal. MRI you could acquire. Like if you see in some movies, they will tell like a Vanjaramina cut panni vecha mari. This is an axial plane of the MRI. You could acquire in a sagittal, like seeing from the side, coronal, or seeing from the front. This is one sequence in MRI called as a T2 weighted sequences. MRI, these imaging appearances are based on the water content in the brain. Because depends upon the hydrogen and water content in the brain, it appears different characteristics in different sequences. This is a T2 weighted sequence where all fluid, in the previous CT I showed the ventricular fluid will be black. In the T2 weighted sequence, the ventricular fluid will be bright in color. This is a ventricle, axial T2 weighted image. This is a diffusion weighted image. So particularly in a stroke patient, you have to see the diffusion weighted image. If it is bright, it is infarcted tissue. It could not be recovered, dead tissue. Okay, this is a diffusion. This is another sequence in an MRI, apparent diffusion coefficient. This has to be interpreted. Diffusion weighted imaging and apparent diffusion coefficient particularly is useful for a stroke patients. If it is appearing bright and black, it has to be interpreted together like a husband and wife. If it is bright in diffusion and black in ADC, it indicates a totally necrotic tissue which could not be salvageable. If the patient is in the window period, like 4.5 hours, can be given IV thrombolysis. If it is a large vessel occlusion, you could refer to a center for a thrombectomy. So the important sequence which you need to look into in a patient with a stroke is a diffusion weighted imaging. Next, sometimes somebody in a pediatric or in an adult patient with an headache, if you see the ventricle will be normally small. If the ventricle is dilated, it is called as an hydrocephalus. It is because of obstruction of the outflow of the ventricle. Normally, the ventricle will be small in caliber. If you see the ventricle is dilated, there are lateral ventricle, third ventricle, and fourth ventricle. This is a lateral ventricle. Both are dilated. This is a CT image. In the CT image, ventricle fluid will be black in color. In an MRI, the ventricle fluid will be white depending upon the sequence. This is a T2 weighted image. This is an headache in a 23-year-old female. As I said, in a reproductive age group, the important thing you have to rule out dural sinus thrombosis or a hemorrhagic infarct. This patient was referred like that. You see there is no bright areas. There is no hemorrhage. Okay, but there is a lesion in the region of foramen of Monro. This is obstructing the ventricle. This is a tumor in the brain. So for tumors, for better characterization, if you identify, like a CT is a screening tool or like a platform ticket, if you identify the abnormality, then the patient can be referred for an MRI for further assessment. This is a contrast. There are two sequences in a CT. One is a plain CT scan. Contrast. Routinely, contrast is not done for an acute setting. When the contrast is given is for a tumor cases or patient suspected with an infection. This with contrast you could see enhancing. This is a tumor which is enhancing in the region of foramen of Monro. This is a subependymal giant cell astrocytoma. This is a 17-year-old adolescent child with an headache. You could see sometimes the tolerance level for us is very high. We report to the hospital or to the doctor at a very late stage. This child was having an headache. Parents were telling it's only a normal headache with a paracetamol over the counter they were giving. So when they come, the patient headache pain score was more. When it was imaged, you could see a large cystic lesion. This is a contrast CT with an enhancing mural nodule. This is a tumor in the brain. This is a pleomorphic xanthoastrocytoma. This is a headache. Headache could have many associated features. This is a patient with an headache with a seizure disorder. They thought it could be a postictal headache, but since the patient had 2-3 episodes in a day, the patient was referred for imaging. So you could see normally, you could see outer will be the gray matter, inner will be the white matter. You could see a large hypodense area. This hypodense area, there are some specks of hyperdensity. These specks of hyperdensity are not hemorrhage, these are calcification. This hypodense area with a calcification indicates is a tumor. Particularly in this context, it could be a oligodendroglioma. So next, similar to an headache with a seizure disorder in around 15 to 20-year-old child, this is a post-contrast CT scan shows multiple enhancing lesions. Particularly in our context in a developing country, when the patient has like a neck signs with an headache, you have to give a contrast and see. This is a increased meningeal enhancement with multiple enhancing granuloma. This is a meningitis with a multiple tuberculoma. So whenever there is an headache, you should look for associated features. So like a meningeal signs means you have to rule out meningitis. In a case of a meningitis, only when the X-ray is more, it could be picked up on a plane. Otherwise, we have to do a contrast. You could see the increased leptomeningeal enhancement. These patients should not be subjected for an LP if there could be coning could happen with increased ICT. As I said, MR is particularly useful for this infective setting. This is another sequence in an MRI, T1 weighted image. This is T2 weighted image. So why these sequences are important in MR? Further characterization of the pathology. How it appears in different sequences, we could tell what could be the pathology. This is a T1 weighted, this is a T2 weighted image. This is a post-contrast. Usually in the T1, CSF will be black. In T2, CSF will be bright. If you remember these two sequences, it is more than enough. T1, CSF will be black. In T2, CSF will be bright. This is a post-contrast. You could see an enhancing lesion. This is also a case of a tuberculoma, particularly in our country with high incidence of tuberculosis, is one which could be a treatable cause. Next, this patient had a headache with fever. So he underwent a CT which showed a hypodensity. When this type of discrete hypodensity is there, you can give a contrast and see. When there is no significant abnormal enhancement, next you have to go for a further imaging with an MRI. In an MRI, you could see compared with CT, the amount of abnormality is more. This is a post-contrast MRI shows an enhancement. This is an infective cerebritis stage. If it is treated early, we could prevent progressing into an abscess. So if it is not treated early, later it will form an abscess. You could see a ring enhancing lesion in the left temporal lobe. So these infective stages, if it is picked up early, patient should be admitted, given IV antibiotic. We could prevent progression to form an abscess and a mass effect. These are the thick-walled abscess. You could see ring enhancement. This is a post-contrast MRI. These abnormalities could be better. These infective abnormality could be better picked up on MRI compared to a CT. This will help in differentiating tuberculoma from cysticercosis. If scolex is seen, it could be a cysticercosis. If it is not, it could be a tuberculoma. As I said, if the headache is associated with a seizure disorder, particularly in a pediatric age group, the important investigation should be an MRI. You could see this is one more sequence in an MRI. This is a coronal, like seeing from the front. Coronal image. This is the important region for seizure disorder is a hippocampus. In the coronal plane, this is a temporal horn, this is a lateral ventricle, temporal horn, this is on the right side, this is left side. Compared to the left side, right side is smaller. This is one of the cause for the refractory epilepsy and a headache. If this is identified, if the patient could be started on anti-epileptic, if he is not responding, patient could undergo a surgery which could prevent the seizure disorder as well as a headache. Next is a patient is having a altered sensorium with an headache. CT showed very subtle abnormality in the temporal lobe. This is an MRI showing compared to MRI. Usually when the patient is having an altered sensorium, CT is not picked up. When there is a neurological radio clinical dissociation, then you could ask for an MRI. Clinical radiological, if it is not correlating with the CT, then you could ask for an MRI. You could see the entire temporal lobe compared to the left side, right side is hyperintense. Patient with altered sensorium with a low-grade fever. This is herpes simplex encephalitis. If it is not treated early, it could be worsened. So this patient could be started on acyclovir, which could be curative. Next, particularly somebody like a throbbing headache, like a pulsatile headache, it could be due to a vascular causes. Previous speakers spoke about temporal arteritis, where the giant cell superficial temporal artery will be inflamed. This patient will also have a pulsed throbbing headache, pulsatile headache. You could see, if you could identify, this is a T2 weighted MRI image. You could see normally this is a inside will be the white matter, outside will be the gray matter. This is normal on the right side. On the left side, if you see multiple abnormal areas, these are called the flow voids. In MRI, we call it as a flow voids. The vessels are hypertrophied and prominent with mild gliosis. This is a case of a vascular abnormality which is causing the headache, which could cause the brain hemorrhage also. This could be treated by surgical excision or with embolization. Okay, I think I had finished. If any doubts means useful, I could answer. The main aim of this talk is when you have to use CT, when you have to MRI. In the current era of neurology, there is no role for X-ray or anything. Predominantly, it's a CT or MRI. In an acute clinical setting, you could ask for a CT. In a chronic setting or with a bizarre clinical radiological dissociation, you could ask for an MRI. In a pediatric, MRI is the standard of care because it has got less radiation, no radiation. Thank you.
Thank you, Parigarapan sir. Wonderful presentation. Because there are so many questions in the chat box, like when to do
Yes,
a CT, when to do a MRI. Probably this has answered most of the questions. And Bala sir, there are one or two questions, but not related to our headache topic. One is treatment of cervical dystonia, and it could be related to COVID vaccine.
Okay. And I have not heard about cervical dystonia related to COVID vaccine. COVID vaccine has been reported with a lot of autoimmune related demyelination. That demyelination producing a dystonia. That way we can take that way. So otherwise, so it produces
Unlikely. Okay.
cervical demyelination. That demyelination produces spastic dystonias. That's possible. And treatment of cervical dystonia is botulinum toxin is the treatment of option. And resistant to botulinum toxin, we can go for surgical corrections. That's very rare. Now, we go for a botulinum toxin, and even if the botulinum toxin therapy they are not affordable and facilities are not available, we can go with the start with the triaxylfenadil. I can start slowly and then increase very slowly over 2 to 3 months. The dose that we go for, but this cervical dystonia, nearly about 7 TDS, that means 14 milligram, 14 milligram, 14 milligram, that much high doses we go for writer's cramp and cervical dystonia. The botulinum toxin, they are not affordable, and botulinum toxin could not be given. But the drug of treatment of choice is botulinum toxin for cervical dystonia. And we should rule out, before saying it's a primary, we should rule out secondary cause for cervical dystonia. If it's acute drug induced or subacute, after taking drug, it could be still drug-induced orofacial, and sometimes metabolic errors also can produce dystonia. These are the related phenomena that we had to. I think that we are running short of time and we can take up
Yes,
all
sir.
the
Balapuran sir,
Yes.
yeah, I think an interesting question. One
Yes, sir.
doctor has asked when to suggest a CT scan during pregnancy. I
Okay.
particularly want to ask this question, like to enlighten.
So,
Periyarpan, are you online? Dr.
Yeah,
Periyarpan? Yeah.
I'm online. We should not do CT scan in a pregnancy at all. We should never do CT scan. MRI also only maybe if it is definitely going to alter the management, we need to do it. Otherwise, we should not.
Well, the reason I asked this question was everyone knows it, because X-ray and radiation is avoided during pregnancy, and you write a radiation hazard anywhere else. But I don't want context. The doctor asked this question. So, is there any specific?
I will modify this question.
Yeah.
Just if somebody in a pregnancy sustains an RTA, you can subject the patient for an MRI. Suspect if somebody in a pregnant female who meets with an accident with an altered sensorium or a seizure disorder, you could ask for an MRI rather than a CT scan.
And I like differ in this angle. If the person comes with acute neurological deficits, when you compare the side effects of CT versus delaying the diagnosis, and you can go with the CT scan, because the association has very clearly said that the CT scan can be done when there is a strong indication of doing a CT scan, especially when the person's GCS is poor and then a head injury. These are the indications in considering the outcome of these patients. That's the one thing that we have reference from the OG association also, because acute stroke. So ideally we go for an MRI, but when you don't have facility, but we have to go for the possibilities of hemorrhage you are thinking or head injury you are thinking. In that case, expanding the risk, you are justified in doing in the city. But as Perikapans are very clearly said that never do routine CT scan for a pregnant. That's not advisable at all.
Yes, sir. One more question. Is there any MRI findings conclusive to any migraine diagnosis, or you don't have any findings in an MRI in any of the sequences you take?
It will be a non-specific white matter hyperintense signal changes. We cannot pinpoint this is due to migraine. If all other causes are ruled out, like ischemic changes, other things, it could be due to migrainous, or it could be a mild small vessel ischemic changes. There is no telltale sign to tell this is due to a migraine.
Yes, sir.
Okay. Yes, sir. Rangarajan sir, any other questions?
Not much. ஒரே ஒரு ஃபைனல் இது வந்து how to diagnose psychological seizure.
We will be discussing in our course, but psychological seizure first. The phenomenon is the most important, and there should be one topic on non-epileptic events, how much is psychological, non-psychological. So one is the phenomenology, the situation, distractibility. These are the things that gives the clue.
I think if there are no further questions, Bala, you can summarize and we can complete.
Yes, sir.
And I think we have somebody asked me to share the slide. Yeah. So, sir, concluding remarks by the director. So, this is the for the taste we have given what we are going to do in the office practice neurology and emergency neurology. Hope you all enjoy, and those who join the course, we are going to take them all those epilepsy, stroke, and vertigo, the common 5 major issues in dealing with in your general practice.
Yes, sir. Yes, sir. So, Rangarajan sir, shall I propose the vote of thanks if there are no more questions?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Okay. So I thank all of you, all the participants who are still attending even after 3 hours. It is around 750 people are still attending, sir. So that shows the quality of content being given in this CME today, sir. And as you told, like this is a prelude to like what the course has in store for the people who attended. So I would like to thank Dr. Balamurugan sir for taking the initiative to coordinate this course. When I asked him after a conference last year at Salem Medical College, can we start a course? And he told immediately, okay, we can do it. It's not an issue. So it has taken this much time to come into shape. So I really thank him for taking this, for bringing up this course, sir. Hope so, as you told, in the future it will be a more sought out course in CGP, sir. And all the eminent speakers, right from Lakshmi Narasimhan sir, one of the stalwarts in neurology from Madras Medical College, now at Ramchandra, and Dr. Meenakshi Sundaram sir, famous neurologist down south near our place, Madurai, and also Rangarajan sir, as we all know, he is not only a famous neurologist, he is also big in IMA.
Yes, sir. We are not able to hear you. And then we
Voice
can...
cut ஆகுது ஆனந்த்.
Yeah.
ஆனந்த் வாய்ஸ் கட் ஆகுது.
Yes, sir. So, yes, sir. So
I think he's traveling, sir.
Thank you,
I
sir.
think he's traveling. We can.
Yes, sir. Thank you, sir.
Thank you. Thank
So,
you.
bye. Bye.
Bye bye. Thank you. Thank you, friends, for all your presentation. Thank you. Thank you.